an honor for us to welcome the distinguished panel of our guests who have graced the occasion with their presence and are here to guide us through the CRE workshop.
I would like to have a round of applause for the distinguished guests for the CRE workshop of today. A round of applause to the guests. First of all, I would like to welcome Padma Shri Gautam sir, Shiv Gautam sir, to this event. A huge round of applause to Padma Shri Dr. Shiv Gautam sir to the CRE workshop conducted by MJRP University. Secondly, Garima ma'am, we on behalf of MJRP University welcome you to the event. Next, Dr. Kumar sir. Dr. Shiv Kumar Sharma sir from Faridabad to the CRE workshop organized by MJRP University. A huge round of applause to sir.
Gajananam bhoot ganadhisevitam kabit jambu phalam charu bhakshanam umasutam shok vinashikarakam namami Vigneshwar pad pankajam.
For the auspicious beginning of today's workshop, we shall commence with the lighting of the ceremonial lamp, a timeless tradition that signifies the dispelling of darkness and the awakening of inner wisdom. I now invite our esteemed dignitaries with our esteemed chairperson, Sir Nirmal Pawar, sir, to the stage for the lighting of the lamp ceremony. I request the music department to play a devotional song on the background.
दस साल तक हर महीने 30,000 पर मंथ इन्वेस्ट करो और 20 साल
Lord Ganesha, lovingly known as Vignaharta, is worshipped as the remover of obstacles and the harbinger of wisdom, clarity, and new beginnings. His presence is invoked at the start of every sacred and significant event to ensure success, harmony, and enlightenment.
To begin with today's proceedings, on a spiritual note, let us invite Lord Ganesha into this space through a vibrant and devotional classical performance.
वक्रतुण्डमहाकाय सूर्यकोटिसमप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा। गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि।
सिंदूर लाल चढ़ायो अच्छा गजमुख को, दिल लाल विराजे सुत गौरी हर को, हाथ लिए गुड़ लड्डू साई सुरवर को, महिमा कहे न जाए लागत हूँ पद को। जय देव जय देव जय जय जी गणराज विद्या सुखदाता, धन्य तुम्हारो दर्शन मेरा मन रमता। जय देव जय देव खालील लुटांगण वंदिन चरण डोळ्यान पाहिन रूप तुझे, प्रेमे अलंगिन आनंद पूजन भावे वाळीन म्हणे नामा। त्वमेव माता पिता त्वमेव, त्वमेव बन्धुश्च सखा त्वमेव, त्वमेव विद्या करुणं त्वमेव, त्वमेव सर्वं मम देव देव। हरे राम राम राम।
Thank you, students.
Children do learn what they live, and they grow up to live what they have learned, which emphasizes the concept of tabula rasa by John Locke.
On this significant and insightful CRE workshop on the topic, exceptional variation in child development, assessments, and interventions, on the behalf of MJRP University and all the participants present here, we would like to present a memento to all the guests and the dignitaries for today's session. First of all, Dr. Shiv Gautam sir, I request our esteemed chairperson sir, Sir Nirmal Pawar sir, to present memento to the dignitaries of the event. First, Dr. Shiv Gautam sir, huge round of applause to sir for being here, a part of today's workshop.
Garima ma'am.
Next, Dr. Shiv Kumar Sharma sir. A huge round of applause to all the dignitaries who accepted our invitation and are present for the workshop today. Today's workshop offers us the opportunity to deepen our awareness and enhance our skills, to identify exceptional variations, to assess them appropriately, and most importantly, to learn how to intervene in ways that empower, not label. It is a day of learning, collaboration, and shared vision for more inclusive child development practices.
This workshop brings to light an essential aspect of our professional and academic journey: the recognition that child development does not follow a single uniform path. Every child is unique in how they grow, express, learn, and adapt. Some may reach milestones quickly, while others move through different developmental patterns that require us to shift our lens from comparison to compassion, from expectation to understanding.
It is an honor to welcome with us Dr. Shiv Gautam sir, Director, Professor, GHRC and Gautam Institute of Behavioral Sciences and Alternate Medicine. Dr. Shiv Gautam is one of the eminent psychiatrists in our country who is at present the Director and Professor of Psychiatry at Gautam Institute of Human Behavior and Alternative Medicine. Dr. Gautam, who was formerly the additional principal of the Savai Man Singh Medical College, Jaipur, and former member secretary of Rajasthan State Mental Health Authority, is known for his contribution to mental health education to masses through the print and electronic media. With a huge round of applause, I would love to be blessed to invite you, sir, Dr. Shiv Gautam, for the session on mental health of children with disabilities and developmental disorders, internalized and externalized problems. A huge round of applause for Dr. Shiv Gautam, sir.
Chairman of today's program and Chancellor of the University, my dear friend Nirmal Pawar sir, my esteemed friend Dr. Shiv Kumar Sharma. We are together since 1966, a long association. Yesterday when I received the call from Nirmal sir, he said you have to come at a very short notice. We had a get together of our friends who are together, studied in MBBS and being in touch since 1968. And this lively group was with us yesterday. I slept at 2:30 a.m. and I could not refuse the warm invitation which you gave, sir, and I am with you. It is an important program today. I have not come prepared for a lecture because I was told that I have to introduce the subject in about 15 minutes' time. And inspire the students. I do not know how much I will be able to inspire, but this is a fact that the profession which you are aspiring for is a very important profession. Mental health cannot be limited to handful psychiatrists or clinical psychologists. In fact, if we look at the population of the country, 10% people are such who require urgent intervention for one or the other mental health issue. When we look at abnormalities, these are 10% people are those who require urgent intervention. But the human problems which are there in the society and the way anxiety, depression, and other health issues which are growing in the community, not only India, all over the world. American population, the statistics says 40% people suffer from depression. In Indian population, 20% people suffer from depression. And situational problems are so much that half the population would require some kind of psychological intervention at any point in time in their lifetime. If we look at the population of children, let aside the children who need special education, children who suffer from one or the other problems like learning disabilities, dyslexias, dysgraphias, and other things. Other issues which are coming up are the behavioral problems. The behavioral addiction, small screen. In older days, I remember when I had just started my mental health practice 51 years ago. 51 years I am in the profession now. Those days we used to have children who were opium addicts, children opium addicts. And how they would be opium addicts? Because labor class women, when they go for work, they would give small dose of opium to the child so that the child sleeps whole day, and when she comes back home, the child is awake and he is fine, and the child does not need lot of care at that point in time. Now that opium, which was 51 years ago, and till about 40 years, 30 years ago, has now been replaced by mobile phone. Every mother, when she wants to work, and if the child is disturbing, she gives the mobile phone in the hand of the child, and the child is busy with the small screen. And you will be surprised to know that the neurocircuitry changes which develop by the use of mobile phone for a longer time are almost similar to what changes occur in opium addiction. One is the behavioral addiction, other is the substance use addiction. And these kind of problems which are coming up now would be the challenges before you, the young generation, when you deal with your clients. Interpersonal relationship problems, family problems, problems between husband and wife, the kind of issues which come up. We look at the child. Child is one. But when you go into the deep roots of the conflict, it is the family. Many families where there are skewed relationship, there is schism in the family, interpersonal problems between the parents, and the little one observing as he grows up, they develop different attitudes towards the parents than what it used to be some time ago or maybe decades ago. And these are the kind of problems which you are going to face and going to be challenges ahead in the newer population. Well, in your course curriculum, you are taught how to handle children with special issues. Learning disabilities, yes, you have to know them. You have to make assessment. Attention deficit hyperkinetic syndrome children, ADHD, you have to know, and it is a part of your curriculum. Children with mental handicap, low intellectual disability, children with organic brain dysfunction in the childhood following infections of the central nervous system. These are the core problems which are the clinical problems. But the behavioral problems are subclinical problems. And these subclinical problems, when they develop into clinical problems, that is the fine differentiating line, which one has to understand. And all of you who are going to be a part of the mental health care providing team, maybe in the school as school counselors, maybe in the clinical setups, in the hospitals, maybe in a clinical OPD setup of a mental health clinic, or maybe your own personal psychological services clinic. You are going to deal with all these problems, and you have to be well versed with them. When we work with mental health issues, it is not only disease, you have to deal with a human being. And how do we define a human being? A human being is a bio, psycho, socio, cultural, religious unit. All these components, the biological component. A person has a biology. He has a central nervous system. He has an endocrinal system. He has all systems of the body, and the systemic infections which occur in the body influence your mind, and you have behavioral abnormalities. It is very simple to say that the person is suffering from typhoid fever. But a person when goes into a delirium because of the typhoid, his mental abilities are disturbed, and he is delirious, he is disoriented, he is behaving abnormally. If a person who is suffering from an endocrinal disorder, maybe thyroid dysfunction or other endocrinal dysfunctions, they suffer from behavioral issues. And we sometimes, the medical model in which we were trained, that medical model talks of the system, but forgets that there is a human being attached with this system. You treat an abnormality of the body, then the treatment is not complete. And therefore, apart from psychiatrists, medical doctors, we need the entire team of people who have to deal with different mental health issues. Many patients whom I treat, apart from medication, day in and day out, I take help of my colleagues who are from the discipline of psychology. And I always speak, some of my students are sitting here, I can see in the crowd. They have seen me observing, they have observed me saying that it is only 70% which you can change by biological manipulation, by giving medication and bringing a balance in the neurotransmitters of the brain. 30% you cannot do until unless you do parallel counseling, psychotherapy, behavior therapy, or other modules of treatment, and then only the person recovers completely. We give medication, but there is a limit. After some time, the medication has to be stopped. And this person has to be rehabilitated back into the society, the work which he was doing earlier, prior to he became sick, what we call as pre-morbid personality. And the person has to go at a pre-morbid level. Only then the treatment is effective. So, the challenge is huge. If you take only 10% sick people who need urgent intervention, 140 crore people, 10% is at least 14 crores. And what is the manpower available? We have about 10,000 psychiatrists in the country. We now have about 5,000 clinical psychologists in the country, maybe a little less than that. We now have special educators to the tune of 2,000, 3,000. Maybe in all, including the psychiatric nurses, the mental health professionals we have in the country would be about 20,000 or maybe 25,000. 25,000 people to treat 14 crores of acute intervention needing people. Let aside treatment. आप एक लाइन में खड़ा करके उनके दर्शन भी करना चाहें तो नहीं कर पाएंगे. The gap is big and we have to fill this gap. And this gap can be filled only when all of you who are sitting here not only become clinician but also become leaders in mental health. Why I say leaders in mental health? Because there is another big challenge which is prevalent in the society. And this big challenge is the stigma. Stigma of mental illness. No mother wants that her child is diagnosed or labeled as suffering.
extra time with the child, it is because of the lack of exposure, not because of the any psychiatric illness. So first thing is this. And the second thing is, like, if an 11-year-old child is presented with a strong interest in video games and index visual motor and problem solving ability, but they are facing difficulty reading an English paragraph. So the teachers might be saying that he's just picking up the issues, or the parents are also. Specifically in our society, what usually happens, पेरेंट्स हैव अ परसेप्शन बाकी चीजें तो बड़े अच्छे से कर पा रहा है बस पढ़ाई ही नहीं कर पा रहा है दिस माइट बी लाइक करना नहीं चाहता है क्योंकि अगर करना चाहता है नहीं तो बाकी चीजें भी तो हो पा रही है व्हाई इट इज स्पेसिफिक टू द लर्निंग ओनली So in those cases, if you are working in a school as being a special educator, it's your duty to look out for the symptoms. Do not go for this thing. It is limited to the education only, so it cannot be a problem. It can be, that's why it is known as a specific learning. Its name is suggesting it is very specific to the learning. So just look for the things. Do not say कि बच्चा बाकी चीजें कर पा रहा है. Yes, they have the capacity. They have an intact IQ, ना? That's why they are able to do the other things, but not specific to the learning. So I just highlighted these two cases because it happens multiple times. Parents either are not able to accept the fact that the child is not having any problem, or they are not able to accept the fact that the child has a problem. So in both the cases, it becomes your responsibility to give a good psychoeducation. I would consider that psychoeducation is a zero-step of therapy. Doesn't matter what the problem is happening, do give a good psychoeducation. We actually underestimate the psychoeducation. There are multiple models. Information model, peer supervision model, group therapy model, which we give the psychoeducation. Your task is not just telling कि ये है और हो गया. No, your task is actually desensitizing them with those things. What can happen in the future? What are the treatment options? And what sort of techniques they can use at the home just to make the things go better and at least to manage the things. Okay, so let's start for the learning disability. As I told you, it is something where you are just facing difficulty in processing the language. Maybe it is spoken, maybe it is written, and that's why they face difficulty in comprehending and speaking, reading, writing. So these are the common things which usually special educators get so very easy once they see the book of a child. The next thing is, I would say it's a common illness. And still it's not common. Next one please. Why it is common? Because in India 10 to 12% of school-going children have SLD. And why it's not common? Because that remain undiagnosed. We are not actually able to diagnose it appropriately. Okay, so when I am saying the diagnosis, I am not saying to label the person. Diagnosis is not always the label. Why is diagnosis come? Because once the child gets the birth, you need the child, na? Just to name out what exactly is happening with the child in the same manner. If someone is having a problem, so we are just telling you, okay, this is coming into this. These are the probable symptoms which they can have, and these might be the mimic of any other issue. So many of the times it remains undiagnosed. Maybe due to of the lack of awareness or lack of special educators in the schools or lack of awareness in the community. And even if it gets diagnosed, like there are chances, many of the times parents just went to a special educator or maybe went to a mental health professional and the thing get diagnosed. So there is a lack of awareness for the remedial programs. We do not know actually what to do. What exactly parents think? Okay, हम extra tuition classes लगा देते हैं, तो ये ठीक हो जाएगा. I seriously have seen this in my practice actually in IBHAS. So in IBHAS we have a proper disability service unit. We do almost 50 assessments, IQ assessments in a day. So that is one of the biggest center of Delhi. तो parents usually have just one concern कि हम ना extra tuition classes लगा देते हैं, वो ठीक हो जाएगा. They are not able to accept or understand the need of a special educator. So we do actually tell them कि special educator, why we are calling them special educator? Because they know the special ways lot of concern. This is the thing. Expect कि मैं बहुत ज़्यादा weird behaviors करूँगा. So do address whatever they are coming to you. Half of your problem get resolved once you address their narratives. They have a lot of stigma in their mind with the mental health issues. And there are a lot of misassumptions with the SLD that are associated. Like people think in SLD people doesn't have a normal IQ. They do have a normal IQ. Even this is the mandatory thing to diagnose a person with SLD. It is mentioned in the Gazette of India. If a child is not having IQ more than 85, then you cannot diagnose that child with SLD. This is the only condition. And once you get someone with a normal IQ, then the parents either go to the spectrum ki he just do not want to study, and or they are not able to accept कि अच्छा ऐसा भी कुछ होता है. So that is also one of the misassumptions that is going on in our society. And many of the times once it get diagnosed, I have seen it that the father is somewhere blaming the mother. It happens क्योंकि तुमने बच्चे पे ध्यान नहीं दिया. The child. SLD is not a result of poor teaching and parenting. Yes, poor teaching and parenting can the symptoms but cannot pop up the symptoms. Nowhere related to teaching and parenting styles. So this is to it is manageable, I feel, rather than the curable, and that's why we are giving a disability certificate over this thing. Na? We issue for the disability certificates for the condition where we know that yes, the things are manageable but cannot be cured, because it is a neurodevelopmental disorder. What does neurodevelopmental disorders means? That there is some issue comes during the developmental years and that is related to the brain structure, like there's some problem in the parietal lobe, that's why they are not able to perceive the shapes and other things. So it is not curable, it is manageable, and there are so many things which makes it manageable. Special educators, remedial programs, here the work of special educators increase a lot. And lack of exposure never leads to SLD. Lack of exposure is not SLD. So that is something which you can create in a behavioral or emotional form of thing, because किसी भी चीज़ का किसी को भी exposure नहीं मिलेगा तो उसको problem होगी. It's और वो कोई disorder नहीं है. That's a very normal thing. One more thing which I would like to highlight, that the parents feel that is not much of like paid attention. कभी कभार क्या होता है, there are certain special issues डोमेस्टिक वायलेंस चल रहा है, नॉट पढ़ नहीं पा रहा है, so that is not SLD. So you have to look, either is a part of emotional or behavioral problems or is an SLD. SLD doesn't have an emotional and behavioral aspect. If it is coming because of the behavioral and emotional aspect, do work on those factors. जैसे वो चीज़ें सबसाइड हो जाएगी, बच्चा पढ़ लेगा क्योंकि उसको कैपेबिलिटी है, बस वो इस वजह से नहीं हो रहा है. एक और special issue which I would like to highlight is a behavior addiction. What happens with the kid SLD? They have a very poor self-esteem. It's actually mentioned in the research. It is not something which I am saying on the basis of my clinical practice. Definitely I have seen it, but it's mentioned in the research also very clearly that they have a poor self-esteem. So poor self-esteem because many of the times they are trying their best and they are not able to do the things. And apart from that, even the teachers or sometimes students are making fun in the class, which leads to the poor self-esteem. And because of that, there are so many needs and so many urges, they are not able to fulfill, and that's why they somewhere involve in a condition which is a very new condition, that is a maladaptive daydreaming. So that is not even diagnosed and even not considered in ICDs and DSMs as a disorder, but this is one of the very new condition, maladaptive daydreaming. Most of the work is done by Alice Sommer, so I am also like more inclined toward that area, because you see a lot of cases in your clinical practice that the parents are coming to you and saying कि ये पढ़ता तो है ही नहीं, लेकिन उसके साथ साथ क्या होता है, पूरा दिन पता नहीं क्या ही अकेला बैठा बैठा थोड़ा सा ना बोलता रहता है, हमें समझ नहीं आता क्या बोल रहा है. So वो जो समझ नहीं आ रहा है ना, so once you explore, the child starts saying that I have an imaginary world in my mind, and that imaginary world I am not able to stop that world. So that is a maladaptive daydreaming. When you are not able to stop the daydreaming, it automatically becomes the maladaptive daydreaming. So that is one of the emerging area. I have multiple research paper also on that you can see it on the SLD children's also, because their needs are not getting fulfilled in the outer world, so they emerged into this thing. Do look for the other issues also in the SLD child. Are they having any other problem also? Like that is not part of the SLD, but that can work as a comorbidity. उसके साथ साथ बच्चे को हो रहा है. So do not miss the symptoms. This is just I would like to highlight. The diagnosis in the DSMs and in the ICD, I just mentioned it from both of the aspects. I don't know that you all must be aware with the diagnosis, but I just would like to brief it, because like if you want to, if you are seeing that it is a case of dyslexia, that the child is going to face difficulty with the reading or with the comprehension, accuracy, that is a dyslexia. But once you talk about the dysgraphia, it means that the child has a difficulty in writing. They are not able to write adequately. It means somewhere they are getting confused between the B, between the D, 6, 9. Those shapes can be seen very clearly. SLD follows a pattern. If you see the sample of SLD, that follow a pattern. So those things are the part of dysgraphia. And for a dysgraphia, there is one more condition which is supposed to be true. Child does not have a dyslexia. अगर बच्चे को dyslexia reading issue है, तो you cannot say कि the child is having dysgraphia. Then that becomes the part of a mixed learning mixed scholastic problem. Next is your dyscalculia. Dyscalculia is like they are facing difficulty with the arithmetic calculations related tasks. And one of the main thing which you have to see, that is not because of the intellectual disability. Child is not facing difficulty because of the compromised IQ, and it is not because of the sensory impairment. Like आप बोल रहे हो बच्चे को ना डिसलेक्सिया है, वो पढ़ नहीं पाता अच्छे से, बच्चे का पीडियाट्रिशियन ने टेस्ट करा, पता चला उसकी तो आई से उसको दिखता ही नहीं है. तो दैट इज़ नॉट अ पार्ट ऑफ SLD. हम जब भी पेशेंट को देखते हैं, वी ऑलवेज डू वन थिंग, हम उसका पहले पूरा असेसमेंट एक फिजिशियन पीडियाट्रिशियन से ज़रूर कराते हैं कि ये उसकी फिजिकल इम्पेयरमेंट की वजह से तो नहीं हो रहा है. You have to mark this line कि this is not a part of physical impairment. This is purely a part of neurodevelopmental disorder. And lack of educational opportunity, that is again the lack of exposure. In the ICD-11, there is nothing like SLD, specific learning disorder जैसा कोई diagnosis नहीं है ICDs में. ICD में diagnose दे रखा है developmental learning disorder, because it is coming during the developmental years, and that again all these things are included. Can we just go to the next slide, please? This I have mentioned the sample of one of my patient. So this is a TVMI. TVMI is your visuomotor ability test, which is under NIMHANS battery. So this is a sample of one of my patient. You can see in the second shape very clearly that the child faces difficulty in perceiving the shape. He is not able to make that reverse triangle. He is trying, but was not able to make. As the shapes are getting complex, child is not able to make that. And even in the last, it's the circles only, but he was not able to make those circles. So अगर आप isolation में देखोगे तो you might say कि बच्चे को mental retardation भी होता है, हो सकता है, but हम SLD assessment करते ही तब है जब हमें IQ normal मिल जाता है, उसके बिना हम SLD करते ही नहीं है. In the written samples also, you will see कि child is facing difficulty in the phonetic cues. जहाँ पे भी double M आ रहा है, कोई भी अक्षर double आ रहा है, he was not able to write. Many of the spelling errors, पंचुएशन मिस है, कहीं फुल स्टॉप, कहीं कॉमा नहीं है. सो इट इज़ फॉलोइंग अ प्रॉपर पैटर्न. इट इज़ नॉट लाइक कि एक जगह ठीक लिख दिया, अगली जगह गलत लिख दिया. इट इज़ प्योर इन अ सीक्वेंस कि हर जगह फनेटिक क्यू ही उससे नहीं हो पा रहा है, हर जगह वो इग्नोर ही कर रहा है पंचुएशंस को. सो वी जस्ट लुक फॉर द सैम्पल वेरी केयरफुली कि इज इट लाइक बाय चांस और हैपनिंग एवरी टाइम, इवन नॉट एवरी टाइम, मोस्ट ऑफ द टाइम्स. Can we just move to the next slide, please? Yeah. So why we are calling SLD a disability? In the DSMs, it's a specific learning disorder. In the ICDs, it is a developmental learning disorder. So where this term specific learning disability come? According to the RPWD Act 2016, that is a Right to Person with Disabilities Act 2016, SLD is considered as a specific learning disability. That was the first time when the SLD was taken as a disability. There was a huge meetings and very long committees also, which leads to this diagnosis. So what exactly happens once you say it a disability? Even not this as a disability, there are many childhood disorders, you must be aware, that has been taken as a disability. So like autism, mental retardation, SLD, they all have been considered a disability. So what actually it is giving to the child or maybe to the society? So we are calling it like a disability just to basically somewhere emphasize that the child's needs are different. So there are many different ways with which the child can be made to achieve certain tasks but in a limited capacity. हम ये नहीं कह सकते ना स्पेशल एजुकेटर से वो नॉर्मल बच्चे की तरह सारी चीज़ें सीख जाएगा, फिर तो वो क्योरेबल हो गया. पर वो तो मैनेजेबल चीज़ है ना, वो बहुत सारी चीज़ें सीख जाएगा अप टू एन एक्सटेंट, वो अवेयर हो जाएगा. लेकिन वो जो एक है ना एस्पेक्ट, वो आपको दिखेगा हमेशा. एजुकेशन में नहीं दिखेगा, बाकी चीज़ों में दिखेगा, कहीं ना कहीं वो ज़रूर दिखेगा. सो and with the RPWD Act, they get a lot of benefits in the education, like getting extra times in the exams, getting the help of the scribes, and modified curriculums, getting the help of NIS, that is an open education system, and disability certificate, which helps them with these things. Apart from this, why this matters? Because it helps somewhere to reduce the stigma. I mean, you might have a question, how it is reducing a stigma? You are empowering someone. You are giving someone the ways how they can at least come to and make their life better. So definitely you are not comparing an individual with the other individual, you are just making them a better life, giving them a better life. That's why it helps them to achieve certain things. And it promotes the educational inclusion. There are nowadays inclusion programs are focused a lot. So if there is a school cannot deny admission under the inclusive programs. There was a time school deny कि नहीं हम नहीं कर पाएंगे. And social acceptance, because कभी भी इंसान mental health problems एक ऐसी चीज़ होती है जो आपके देखने से नहीं पता चलती है. If you are having a fracture in the hand, person can see and tell you कि आपके तो हाथ में चोट लगी है. But mental health problem doesn't matter वो कौन सी mental health problem है, depression, anxiety, anything. No one can identify what you are going through because everything is happening in your mind. So it somewhere increases the social acceptance because वो कहीं ना कहीं बच्चा compete करने में आ जाता है आगे, वो चीज़ें सीख जाता है एटलीस्ट इतना कि अपना तो काफ़ी अच्छे से कर लेता है. Can we just go to the next slide, please? So I actually explained this thing also to you, what actually the criteria. Because if you are a special educator, it is your responsibility to tell the parents what are the ways. You cannot say कि आपके बच्चे को ये हो सकता है and then just leaving the things. No, you have to show them the path. What next? What can they do? So disability certification follows a procedure. First thing I would like to highlight, disability certifications are usually given by the government hospitals only. So you just have to tell the parents, look for the nearby government hospitals in your region who is issuing the disability certificate, and that is very easily like they can come to know from the government websites also. They just go to the websites, or maybe not from the website, they go to the hospital, visit to the hospital, and they will be able to come to know okay, this hospital is issuing the certificate or not. Certificate follows a very long process, which is, I feel, the concerns of the parents also. I actually get this concern from many special educators also कि आप लोग इतना time क्यों लगाते हो. So I want to answer this question कि इतना time भी क्यों लगता है. First thing is कि child has to get a Form A. This step is a Form A. Form A from the school, which is given by the higher authority, maybe from the teachers, maybe from the principal, which mention कि बच्चे को academically क्या problem आ रही है, and the child will just go to the hospital, submit the Form A, and the process starts. First process is the detailed workup. Psychiatry, like child goes to the psychiatry department, they do the detailed workup. Detailed workup is not only the part of psychiatry, clinical psychology trainees also do that. So whosoever is getting that opportunity, they do the detailed workup. Once the detailed workup is done and the diagnosis of SLD is made, then you proceed for the other things. And while the detailed workup is happening, a pediatric assessment also happens कि बच्चे को कोई speech impairment, कोई vision related impairment तो नहीं है, क्योंकि आप बच्चे को सोचो कि वो कर नहीं पा रहा है, पर उसकी physical कहीं ना कहीं limitations बीच में आ रही हो. So we look for those things also. Then the child referred to a clinical psychology department, and what happens, you do a IQ assessment first. You take the history, like it's not कि किसी ने आपको करके दे दिया and then you are just doing the assessment blindly, because you are not a technician, you are a clinician, so it's also your responsibility to check out the things again, like कुछ miss out तो नहीं हो रहा है, is it not a part of emotional and behavioral changes or any other like aspect, maybe lack of exposure and other things. So once you take out the history very properly, then you go to the next step, that is an IQ assessment. So अगर हम IQ assessments की बात करें तो we have a lot of tools. हमारे पास बहुत सारे tools हैं, लेकिन Gadget of India में जो tools disability के लिए mention कर रखे हैं, we can use those tools only. So अगर हम बात करें SLD की, तो SLD के लिए Gadget of India में जो tools mention कर रखे हैं, they are the BKT, Bachelor series, Miss6 series. So these are the only tools which are mentioned in the Gadget of India. So once you do the IQ assessment and IQ comes greater than or equal to 85, then only you proceed for the SLD assessment. Otherwise, it becomes a part of compromised intelligence. So आपका सारा का सारा certification, सारी की सारी remedial program सब बदल जाएगा, जैसे ही अगर IQ इससे नीचे आता है तो. Next is, once you identified कि हाँ इससे ऊपर आ रहा है, then the next thing is applying the SLD battery. There are 2 batteries which are acknowledged by the Gadget of India and which are considered for the certification, and they are the GLAD and the Nimhans SLD battery. So either any of the battery, whichever is like feasible and available to you, you can just apply, and after that you see कि if the child has a below 40% performance, then you proceed for the thing. You just make a report कि okay, so reading में क्या difficulty आ रही है, writing में क्या आ रही है, arithmetic में क्या आ रही है. It is not limited to reading, writing, arithmetic. Comprehension में क्या आ रही है, बच्चा comprehend कर पा रहा है कि नहीं कर पा रहा है, उसकी visuomotor ability कैसी है. एक मैंने आपको TVMI की शीट दिखाई थी, that is for the visuomotor. वो देख के कितना perceive कर पा रहा है, आप उस ability को भी देखते हो. SLD में ऐसा ज़रूरी नहीं है कि आपको सिर्फ आपकी रिटन लैंग्वेज में ही दिखेगा, बहुत सारी चीज़ों में होता है. जैसे कि विजुअल मोटर का एक बड़ा अच्छा एग्जांपल होता है कि जो लड़कियां होती है ना, स्पेसिफिकली व्हेन दे हैव अ विजुअल मोटर कॉम्प्रोमाइज्ड, तो दे आर नॉट एबल टू मेक अ पॉनी. उनको वो कॉम्प्लेक्सिसिटी नहीं समझ में आ रही होती है कि ओके सो हाउ इज इट गोइंग. दैट इज़ ऑल्सो द एग्जाम्पल ऑफ दैट थिंग. सो दिस इज़ द प्रोसीजर विच कम्स फॉर द डिसेबिलिटी सर्टिफिकेशन. Okay, so before going to the autism, once you completed the assessment, then again a board happened. Like you completed the assessment, there are multiple members of the board: pediatrician, psychiatrist, clinical psychologist, and occupational therapist. Then they again assess the child. So this process takes time. Why it is following so many steps? ताकि किसी से अगर किसी स्टेप पे कुछ मिस आउट हो जाए तो एटलीस्ट समवन एल्स विल बी एबल टू आइडेंटिफाई दैट थिंग. इसका मिसयूज़ या फिर ऐसा ना हो कि एक इंसान ने कोई चीज़ को इग्नोर कर दिया है तो कोई और भी इसे सस्पेक्ट नहीं कर पा रहा. इसलिए डिसेबिलिटी सर्टिफिकेशन इज़ नॉट अ प्रोसेस ऑफ वन पर्सन, इट इज़ अ प्रोसेस ऑफ मल्टी-डिसिप्लिनरी टीम. Many people are involved, they do the things, they identify what is happening, and then we go ahead. So the next like topic which we are going to discuss is the autism. Can you just go to the next slide, please? Okay, I actually have mentioned a case for you. This is basically if a 10-year-old boy or a 10-year-old boy is coming to you with a chief complaint that the child is having social withdrawal or somewhere poor academic performance and the odd behaviors in the class from past, I would say 6 months. And his parents reported that he had always been a quite slightly aloof child, but his current behavior has become very strange and unreachable. So like there is a muttering to self is present, and I would say there is a little interest in the peers. Okay. Not maintaining the social relationships. So if this case is coming to you, like how you are going to approach it? I just want the opinions of you. Okay, the case is the question. Like if this case is coming to you, what is your way of approaching it? As a mental health professional? Yeah. Yeah. Yes. Yeah. Yes. Thank you for the response. Yeah. Basically, do not be in a hurry of a diagnosis. Misdiagnosis leads to multiple issues because pay attention very carefully for the symptoms. Like it's mentioned that the child is having difficulty from the past 6 months only. So how it can be a case of a neurodevelopmental काइंड ऑफ प्रॉब्लम ना. पहले तो बच्चा ठीक ही था, तो वो पिछले 6 महीने से ही हो रहा है. सो जस्ट लुक फॉर द सिम्टम्स वेरी केयरफुली. when the symptoms originated, कब onset हुआ है, and look for the emotional and behavioral things also. Many of the times there are things like special issues, bullying, substance use, and violence at the home leads to these form of issues. Yeah. Family plays a very big role. We always follow the biopsychosocial model. We see what the aspect is happening. Yeah, they start mimicking the symptom of any diagnosis many of the times. Can we just go to the next slide, please? Okay, this actually I would like to highlight. Misdiagnosis matters a lot. So there was a time when the childhood onset schizophrenia and autism was considered as a single illness. There was not distinguished between both of these. So whenever you are dealing, just look for the things very carefully. Why it was considered as a single thing? Because there is a similarity in the symptoms. The negative symptoms of schizophrenia are the same as the autism, but the main difference is autism is a neurodevelopmental disorder and the onset starts before the age of 3 years. So you see the things before the age of 3 years. At like 15 years of age, like someone is coming कि 2 महीने से दिक्कत हो रही है, तो just be open for the things कि और कुछ भी हो सकता है. It cannot be part of that thing because of that similarity between the negative symptoms. Affect issue आपको schizophrenia में भी दिखता है. Affect issue आपको फिर autism में भी तो दिखता है ना. Autism का बच्चा emotions को अच्छे से express नहीं कर पा रहा होता है. So, negative symptoms में आपको schizophrenia में दिखता है, उनका social withdrawal start हो जाता है. Autism में भी तो आप यही देखते हो, उसको communication related issues होते हैं. Either they are not able to initiate the conversation, or if they initiated the conversation, it becomes a difficult task for them to continue that conversation. So you just look for the things कि what exactly is happening. हम कुछ और तो नहीं कर रहे हैं, बिकॉज आप जो बनाओगे फिर आप उसी के बेसिस पे आगे इंटरवेंशन को लेके जाओगे. सो जस्ट लुक फॉर द थिंग्स then only go for then only go for a diagnosis and your treatment. Developmental history matters a lot. बच्चे की developmental history कैसे रही है. आपको ऑटिज्म में एक रिग्रेसिव पैटर्न भी दिख जाता है. कभी कभार बच्चे कुछ चीज़ें बोलना शुरू कर देते हैं, लाइक पेरेंट्स कम टू यू एंड स्टार्ट रिपोर्टिंग कि इसने ना 1.5 साल की उम्र में बोलना तो शुरू कर दिया था कुछ शब्द, पर जैसे जैसे बड़ा होता गया वो छोड़ता गया. सो जस्ट लुक फॉर द क्यूज कि ये पहले से हो रहा है कि अभी 1-2 महीने वाली दिक्कत हुई है, तो यू विल गेट अ बेटर आइडिया अबाउट द थिंग्स. नेक्स्ट स्लाइड प्लीज. So how you can identify the autism? Like first the step is to identification. What you are going to make an identification. They have a persistent deficits in the social communication and social interaction. So persistent deficits, this matters a lot. It's not कि एक situation में तो बच्चा कर लिया सब कुछ, अगले situation में नहीं कर पा रहा है. Not situation specific, persistent. This matters a lot. What usually happens, you have a difficulty in initiating, sustaining the conversations, and they have a very reduced interest of, I would say, talking to others, emotions, and usually have a flat affect. Again, your schizophrenia negative symptom, which gives you a confusion. And they have a poorly integrated verbal and non-verbal communication. Like you are talking to a child, so they are not able to make a eye-to-eye contact. Their eye-to-eye contact is very poor. They will not make a eye-to-eye contact. You are saying, okay, hi beta. They do not know, okay, what exactly the gestures. They face difficulty in making the gestures. So these are the particular things, because communication is not related to verbal only. Communication is your non-verbal communication also. So we have to look for all the aspects. The next thing is restricted, repetitive, and inflexible patterns of behavior, interest, or activities. So they have a stereotypical and repetitive motor movements. Hand flapping. They are just hand flapping, going for the hand flapping, and playing with the toys in a very similar manner, in a very unusual manner. Parents we say, गाड़ी को चलाना होता है, but वो करता ही नहीं है वैसे. And sometimes they are hyperactive to sensory input also. Like parents are going to report you कि किसी भी particular आवाज़ से they get very irritable. Maybe they are not able to bear the voice of a I would say pressure cooker, sometimes horns. So hypersensitivity is also present there. And the onset matters a lot. Onset for the autism symptoms is before the age of 3 years. It's mentioned, आपको 3 साल से पहले कुछ symptoms दिखने लग जाते हैं. After that you start making a diagnosis, and symptoms persist and it creates a significant impairment. इसकी वजह से बच्चे को दिक्कत आ रही होती है maintaining the personal relationships और जो भी उसके age appropriate other behaviors होते हैं. Can we just go to the next slide please? हाँ. बात हम अगर ऑटिज़म की करें, और अगर आपको ऑटिज़म के कॉजेज़ में बायोलॉजिकल तो होते ही हैं आपकी, दे आर बायोलॉजिकल कॉजेज़ ऑफ ऑटिज़म. बायोलॉजिकल में लाइक कभी कभार फैमिली हिस्ट्री है, हेरिडिटी है, तो वो एक बहुत बड़ा इंपॉर्टेंट रोल प्ले करती है. और मदर को कुछ कॉम्प्लिकेशंस रहे हैं ड्यूरिंग द बर्थ, दैट प्लेज अ बिग रोल. कोई सब्सटेंस इंटॉक्सिकेशन है ड्यूरिंग द प्रेगनेंसी, दैट इज़ ऑल्सो वन ऑफ द इम्पॉर्टेंट फैक्टर फॉर दिस. सो आपको पता चल गया बच्चे को दिक्कत है, व्हाट नेक्स्ट. अब आप तो उसे स्कूल में पढ़ा नहीं रहे हो. मोस्टली पेरेंट्स हमारे पास इस चीज़ के साथ आते हैं कि अब ना हमें नहीं समझ आ रहा आगे क्या करें. स्कूल बोल रहे हैं कि हम आपके बच्चे को निकाल देंगे क्योंकि आपका बच्चा थोड़ा वियर्डली बिहेव करता है. तो they actually have a lot of apprehension. They sometimes start blaming the self also कि it might be happening because of us. शायद हमने कुछ अच्छे से नहीं किया है. तो it is your duty. As I told you in the psychotherapy, psychoeducation, I would consider it as a 0 step, not even as a first step. Doesn't matter क्या हो रहा है, आपको psychoeducation तो देनी है ना. अगर if it is above 18 or you see that the child is in the age where they can understand about the problems, then you can give it to the child. And if you see that the child is not even in the capacity, or maybe the adult is not in the capacity, because in the cases of schizophrenia adults are not in the capacity, then give it to the informant, family member who are coming कि क्या है, क्या हो सकता है आगे, what are the treatment options, how they can manage it. So when we talk about the disability certification, I hope you all must be aware that on the autism there is a disability certification which is issued. There is a proper procedure for the diagnosis. Incline is applied. So once you there is a possibility of autism on the incline, then you move for the ISA. So ISA में basically क्या होता है? ISA में you just see the severity of the disability before the age of 6 years. Disability certification is a temporary disability certification, and that is issued if the child comes into the moderate autism only. उस पे ही दिया जाता है. It's mentioned in the Gazette of India. Can we just go to the next slide, please? Okay, I just have included the autism ISA scale also for you. It's public. It's like available on the public domain also. गैजेट ऑफ इंडिया में भी दे रखा है आपको. वैसे भी अगर आप ऑनलाइन सर्च करोगे तो यू विल गेट इट वेरी इजीली. सो दीज आर द डोमेन्स विच वी असेस इन द ऑटिज्म फॉर इन दिस स्केल. फर्स्ट इज योर सोशल रिलेशनशिप्स एंड रेसिप्रोसिटी, कि how they are maintaining the social relationships, how much they are reciprocate in the communications relationships whenever they are going, like are they able to maintain a eye-to-eye contact when you are talking to them, how is their eye-to-eye contact, their social smile, because once you talk to someone you actually give some form of non-verbal gestures, na? So are they able to give them, and are they prefer to remain the aloof, how is their social relationship. Many of the times parents will say कि हाँ उसको वो किसी के साथ खेलता ही नहीं है, वो अकेले ही बैठ के खेलता है, घर में इसके इतने सारे कजन्स हैं लेकिन ये खेलता ही नहीं है, अकेले बैठा रहता है, अपने टॉयज़ के साथ अजीब अजीब तरीके से खेलता रहता है. सो यू जस्ट हैव टू लुक फॉर द थिंग्स, all these things. Next is your emotional responsiveness. How is their emotions responsiveness is like inappropriate emotional response. Any of the time start laughing, start crying. So how is their emotional responses are coming? Exaggerated emotions happen. Lack of fear of danger. Parents will say कि कहीं पे भी जाके हाथ लगा दे तो उसको डर ही नहीं लगता है. Those things. Speech, language and communication. How is their communication? Acquired speech and lost, which I told you is a part of regression. बहुत सारी चीज़ें सीखते हैं, छोड़ देते हैं. And difficulty in using non-verbal language and gestures to communicate. वो कैसे communicate कर पा रहे हैं? Engage in stereotypical and repetitive use of language. एक ही शब्द को बार बार बोलना, एक ही चीज़ को repetitive use कर रहे हैं. Echolalia. Echolalia is basically you have said something and they are just repeating the same thing. कभी कभार क्या होता है? There is an immediate echolalia and sometimes there is a delayed. कि उन्होंने कुछ TV में देखा, थोड़ी देर बाद you get the food. Okay, I am a superhero. I am a superhero. Repeating those things again. Next is your parallelia. खुद की चीज़ों को repeat करते रहना. Those things are also present. Unable to initiate the conversation and somehow if they initiated it, they are not able to continue that conversation. उसके बाद behavioral patterns. Look for the behavior patterns. They have a repetitive behavior patterns, so just look for the thing. And they insist a lot on the sameness. When the COVID came, the biggest problem was faced by these kids because स्कूल बंद हो गए थे एकदम से, सब बच्चे घर पे थे and पेरेंट्स को पता ही नहीं था how to handle. And the child has a like capacity कि child की एक tendency होती है sameness पे focus करना, उसका schedule change हो रहा था, तो they were getting very irritable how to manage, how to not manage. So as being a mental health professional, it's your responsibility to tell the parents कि how to manage it at home, what they can do at the home. They are going to be very high chances, बहुत बार जब शायद स्कूल ऑफ होगा या कुछ ऐसी चीज़ें आ गई, they are not able to follow a particular schedule. तो कैसे चीज़ों को मैनेज करना होता है. Next is your sensory aspect. Their sensory aspect. They actually are very sensitive to the sensory stimuli. Sometimes they are sensitive to any smell. Sometimes they are sensitive to any form of noise. Sometimes color, कोई bright color से बहुत ज़्यादा irritability हो रही है. So just look for the things. These are the questions. And they few of the times have unusual vision. Insensitive to pains. Parents will tell you इसको चोट लग जाती है और ये उसको scratch करता रहता है बैठ के, बताता ही नहीं है चोट लगी है. बहुत ही हार्डली कभी ऐसा हुआ है कि वो रोया है चोट लगने के बाद. उसके बाद द लास्ट जो कंपोनेंट होता है हमारे ईसा का, दैट इज़ अबाउट द कॉग्निटिव. So they have an inconsistent attention and concentration. Sometimes they have a savant ability. Savant ability is like child is doing extraordinary in something. I still remember one of my child की गिटार बहुत अच्छा बताता है, कभी ट्रेनिंग नहीं मिली है, still they are able to do those things. So you just do this assessment. Can we go to the next slide, please? So now you have taken the history properly. You actually have applied the tool, done the assessments. What next? What next as being a professional? Then you go for the management. So there's definitely we focus on the management also. So in the management, first thing is we actually have to pay a proper attention on the factors what we are managing. So managing, we focus on the reduction of disruptive behaviors. They do have a lot of disruptive behaviors. Their communication skills, social skills, which they are somewhere lagging, their acquisition of language. It is a part of multidisciplinary team, occupational therapist, speech therapist, everyone is involved in it because they have a limitation of speech also and other things. And the techniques, if we talk about, we use the ABA, applied behavioral analysis, as the name is suggesting. You are just somewhere applying the behavioral analysis. You do the behavior analysis, what are the antecedents, then the beliefs, behavior of the child, the consequences, and then use the techniques accordingly. Social skills training to maintain the social skills of them, to maintain the communication, all those things have been applied. So, and the parent training programs, parents usually have to be taught about the things. They do not know. We cannot assume कि उनको proper knowledge होगी चीज़ों की, because they are the parents ना. They just know as a layman. But if their child is having something, उनको desensitize करना, because once they hear about the things, they get nervous a lot. Somewhere their tendency to blame the self increases. All those things happens. So just educate them properly. Tell them about the things. Include them as a co-therapist also, tell them about the positive reinforcement, whatever the techniques you are using, how they can manage that at home, and then go ahead with the things. Okay, so any questions, guys? This is from my side, just to give you brief about autism and learning disabilities. Okay, then thank you everyone. Yes. Okay, so I just received a question, childhood onset schizophrenia, difference and autism. As I told you, in the schizophrenia, it's not about the negative symptoms only. Na? There are positive symptoms also, delusions, hallucinations, which are not the part of your autism. And apart from that, autism starts before the age of 3 years. But when you are getting the schizophrenia cases, childhood onset, usually it's been mentioned that are one thing that are rare, and the diagnosis or the symptoms starts before the age of 8-9 years. So the difference is between the symptoms and when they persisted, when they started, originated. Parents are going to tell you one thing कि इससे पहले तो ये ठीक था in that thing. Autism में ऐसा कुछ वो नहीं बताते, because that is a neurodevelopmental condition. So that is one of the thing. You just take the history in a very detail, when the symptoms started and what are the symptoms. So, what if, sorry? Yes, the regression starts after the, even after the age of 3 years, still in the childhood integrated disorder, you will see कि speech के लिए चीज़ें आपको early ही दिख जाती है. आप developmental history लोगे ना, तो you will get the things. Like developmental history in the cases of these neurodevelopmental disorders matter a lot. So you will be, and again I told you, positive symptoms तो आपको मिलेंगे नहीं ना. That is one of the things. Yeah. So, okay, thank you everyone.
So I think this quote that autism is not a disease but a different way of experiencing the world makes sense after the wonderful session by Garima ma'am. Thanks a lot. A wonderful round of applause to ma'am again for that insightful session. I would like to take this opportunity to welcome our next keynote speaker for the CRE workshop. A huge round of applause to Dr. Manish Bhargav sir, who has joined our CRE workshop today with MJRP University upon our invitation. A huge round of applause on behalf of MJRP University. So next session would be on the topic childhood disabilities and developmental disorders, epilepsy, mental retardation, causes and the diagnosis.
I request everyone with the CRE number, please come on stage. I request everyone with CRE number, please come on stage. Please come on stage. PCRR and CRR.
आगे रहा कड़ी ना आगे हो जाएंगे मैम इधर हाँ बोलो हेलो हेलो आवाज आ रही है आवाज
I request Meenakshi ma'am to please come up on stage. Smriti ma'am, Abha ma'am, please come on stage. Vishi ma'am, Meenakshi ma'am, Smriti ma'am, Abha ma'am and Vishi ma'am. All in the uniform, please come forward. Please come forward. Hey, boys also can move. Go that side, go that side. आगे उधर चले जाओ. आप आ जाओ. आप इसी में. Thank you, everyone. Remember we met in Delhi, Ibas? You were the one.
And behavioral sciences, known for his work in various hospitals and is associated with National Institute of Medical Science and Research. Bhargav sir is recognized for his expertise in accurate diagnosis, empathetic patient care, also runs Bhargava Psychiatry and De-Addiction and General Hospital in Mansarovar, Jaipur, which provides comprehensive mental health services. The topic for today's session with Bhargav sir would be childhood disabilities and developmental disorders, epilepsy, mental retardation, causes and the diagnosis. With a round of applause, let's welcome sir.
Thank you. I'm Dr. Manish Bhargav, and I thank Mahatma Jyotirao Phule University to invite me for a session. I hope I do the justice. And shall we start? Mental health of children with disabilities and developmental disorder. Presented by me, Dr. Manish Bhargav. We have our own setup, Bhargav Psychiatry, De-Addiction and General Hospital, along with Child Brain Development Center, which caters what we are here collected for today. That is the disabilities, the autistic children, and learning intellectual disabilities and all. Next slide. Can you go to the third or fourth? There is a mixed up in the slide, I believe. Yeah. Disability is a physical and mental condition that limits one or more major life activities substantially. According to PWD Act, person with disability means a person with long-term physical, mental, intellectual or sensory impairment, which in interaction with berries hinders his full or effective participation in society equally with others. I like to add disability in a family will have not impact on the child but as well as the entire family members too. Next slide. Next. The factors which the previous. Today we will be talking about the factors which influences the disabilities in such children. That is the internal factors and the external. Internal factors these are the factors with the child, biological, psychological or developmental, that influence their mental health. Type and severity of disabilities. Children with more severe developmental delays, e.g. Example, profound intellectual disabilities or non-verbal autism, may face greater emotional or behavioral changes in their lives. Cognitive and emotional regulation skills. Difficulty understanding or controlling emotions can increase frustration and anxiety in such children. Communication abilities. Limited abilities to express themselves or their emotions may lead to behavior outbursts or withdrawals. Temperaments. Some children are naturally more anxious, sensitive and reactive to stress according to their coping mechanism. Next. The external factors are the family environment. A nurturing, structured and supportive home foster reliance, resilience. Family stress, conflict or lack of resources can worsen mental health of such children. Parents and caregiver mental health. Caregiver depression, anxiety or burnout can reduce the ability to meet the child's emotional needs. We often see parents complaining कि मैं अब क्या करूं, ये मेरी बात नहीं मानता. This is a very common phrase you will be facing, we also face every day as we run a developmental center. So we make sure that we conduct regular meetings with the entire patient caregivers and parents group, because that is the most necessary part which I have learned. Training a child and training the parents, I'll ask you, what is a better solution for it? Training the child or training the patient in such manner? In Indian scenario, we have to teach the parents first to recognize, come up early. We often see children coming very late to us because of the factors that the family doesn't believe in कि ये बच्चा हमारे इसके कोई mental disorder है, because we are too much tabooed. As a mental health professionals, we have to take it down. We have to educate, call them, parents को बुलाओ, उनके grandparents को बुलाओ, relatives को बुलाओ. गांव से पेरेंट, गांव का पेशेंट है तो उनके सरपंच से भी बात करो आप कि these are the things. Conduct your outreach clinics in such villages where you can teach them and make them learn to identify different intellectual disabilities in the children there. Because majority of our population resides in villages. Cities, parents do come up, and especially after the movie Tare Zameen Par, we have lot of patients increased in learning disabilities. And with the new movie Sitare Zameen Par, we'll have more of people coming to us ki make them a normal person. So this is a challenge we are facing every day. We have to be very truthful to them about this is the capability, this is the capacity your child can grow to. The previous slide. Social inclusion, peer relationship. Loneliness, bullying or social rejection can lead to depression or anxiety. Inclusive friendship promote well-being. I remember I was working in England and they have a very beautiful structured setup for such children. The NHS provide every means to the parents, to the child. They train them free of cost. They take them out on trips. They take the children to the various restaurants, to movie hall. For the social inclusion is must for such children, because the parents should feel that my child is capable of doing such things. They should not feel ashamed कि मैं जाऊंगा restaurant, मेरा बच्चा कूदेगा. 1 or 2 times the child will do so, but the 3rd time we might succeed in telling them that your child is sitting normally eating with cutlery. That should be the aim of the caregivers and us to promote such things. School environment. A supportive, inclusive educational setting with trained staff can reduce stress. This one point we lack in India, because as the previous speaker, she mentioned that we go to the school, the teachers after a while they say ki sab, there is a problem in your child, get them assessed. And then once the assessment is done, they try to send the child to a special educators. So I think so all the public schools or the universities should come up with 1 or 2 classes of such children in a normal school, rather than giving the name of a special school. Access to service, lack of access to therapy, early intervention or special education service may lead to undamaged behavior or emotional issues to the parents. Yes, we do agree that the cost effectiveness is a major part where these children can't take advantage of the special trainings. Next. Stigma and discrimination. Negative attitudes or lack of acceptance from others, including educators, peers or the community, can affect child's sense of self-worth. We should not make them feel. In your clinical practice, I'll tell you a small little gesture. When they come to you, shake hand with them, let them, for 2 or 3 minutes, let them do whatever they want to do in your chamber. Just don't say sit down or this thing. Again, your patience is tested there rather than child's patience or the parents. You have to be patient. 5 minutes, all you have to give to the child, observe them, they will be the friendliest child to you. They will sit and listen to you. Should not make the parents feel that, okay, I'm not happy with this child's attitude in my chamber. Cultural belief, family or community beliefs about disability can influence whether the child receives support or faces additional stigma. Cut it out. Make them as normal as possible. But again, in their own capacity and capability. Economic stability. We do run a CDC. We charge. But there are certain government grants which help these children. PWD gives you grants for such children to be trained elsewhere, irrespective of the schools run by the government. Next slide. Interaction of internal and external factors. These factors should be addressed simultaneously. For example, a child with limited speech, internal, in an unsupportive school, external, may develop anxiety or depression because of various reasons. Conversely, a child with severe autism, that is internal, who has a strong support system, external, may have better mental health problems. Again, in the Western world, the autistic spectrum they train them. After certain years, the government take them in their own this thing and they train them for little bit, like they will make them work at a till, they will make them work on a shelves, they provide. So we need to address that कोई ना कोई एक capability उसकी ऐसी develop कर दो so he can run his life, because we don't know the expectancy of life in such children. Yeah. Internalizing problems definition is inward directed emotional difficulties. We have gone through this. Common manifestations are like excessive worry, sadness, irritability, avoidance of social and academic activities, somatic complaints, headache, stomach aches. These are all points which will affect a child's learning capabilities. Poor scholastic performance will be happening in such things where the child do. And especially in our day-to-day practice, a lot of ADHD children, they do such things where they will have stomach, somatic complaints because they want to run away from the studies. Key contributing factors are genetic predisposition and neurobiology, that is what we call the developmental disorders, sensory sensitivity, family conflict, rigid parenting, experience of exclusion and stigma. Next slide. Externalizing problems, outward directed disruptive behavior. The child may develop aggression, defenses, rule breaking, hyperactivity and impulsivity. Conduct and oppositional disorders. With the phone addiction, conduct disorder is on a high and alarming rate. I don't know how many people will agree with me. We are seeing more of oppositional disorders and conduct disorders and ADHD now, because these are the key concern to regulate where the child will have problems in a later life. Contributing factors to such are ineffective, inconsistent parenting. Again, parenting plays the role. We have to tell them, we have to judge how the parenting is being done. A very common thing, ki sab, my 8-year-old daughter बहुत फैशन करने लग गई है. So the thing is, आप क्या कर रहे हैं as a parent? Because they are copying you. They have all the means to learn about fashion from advertisements, from phone and self, like mother, parents, we do, and they copy us at times. Exposure to violence, trauma, they are all contributory factors. Too much of, you put up any phone or anywhere we listen to violence, trauma. Even there are certain cartoon characters which contribute to trauma, violence, hitting, shouting. The child is learning, they are grasping things from there also. Association with deviant peers, emotional self-regulation deficits. When to seek help? Sudden behavior changes if observed in the child. Excessive crying, irritability or aggression increased. I'll put demands also here. Withdrawal from activities or people. Changes in sleep or appetite. Regression in behavior or skills. This is entire spectrum. We are not talking about just ASD or anything. This is entire intellectual disabilities which will which will result in such things, we need to seek help immediately by a psychiatrist, a pediatrician, by child counselors, and everybody. Next slide. Just neurodevelopment, I was asked to talk about certain diseases also. So I have picked up epilepsy. Childhood epilepsy, it's a neurological disorder that causes repeated unprovoked seizures. Lot of cases in ASD or mental retardation, ADHD and all, you will have comorbid mental disorders, which is on the increase. The speaker talked about schizophrenia. Then there are certain things that we experience, childhood epilepsy aati hai, which results later on in certain syndromes. Seizures are sudden surge of abnormal electrical activity in the brain, can affect awareness, movement, behavior or feelings. Common causes of epilepsy is genetic, that is family history, genetic predisposition in any form of disease is always there. Brain injury, trauma, stroke or infections acquired in early childhood. Birth complications, brain tumors, developmental disorders like autism, I said. Again, we are emphasizing too much of autism, but what in my clinical this thing is, ADHD and learning disabilities are far more we are seeing in our day-to-day practice. And there is many cases the exact cause is not known. Next slide. How is epilepsy diagnosed? Again, a detailed history, medical history and detailed description of seizures, neurological exam of to check brain functions, EEG, MRI, scans, blood test. I know this is not your domain, but again, it helps you, the parent coming with a seizure disorder to you, or it's a comorbid something. So we should have a little bit knowledge about these tests, that have you done this. Next. Intellectual disabilities, as the workshop will be talking about. It's a condition marked by significant limitations in all fields. Intellectual functioning, reasoning, learning, problem solving is all affected. Adaptive behavior, communication, daily living. Again, daily living, you learn by your peers, you learn by parents itself, they copy the parents. You learn by all the gadgets. It appears before the age of 18, previously known as mental retardation, now changed. So we are more into intellectual disabilities. Causes of intellectual disability, again genetic conditions, born with it, Down syndrome, Fragile X syndrome and all. Problems during pregnancy, which is on a high rise. Alcohol by mothers, drug abuse, smoking, and even diabetic mothers are more on increase, which may cause intellectual disability. And as you have observed, the pattern of birth giving has shifted to late 20s rather than 22. Now is shifted 4 to 5 years ahead now. Now the basic average age of a pregnant woman is around 28 to 32. Birth complications, again oxygen deprivation, which will have impact on the brain development. Hypoxia is the term when the baby doesn't have enough oxygen when he is born, which leads to seizures and further damages, which we come to know. These are soft tissue injuries which will not surface immediately, but they will surface later in the life of the child. जैसे there was an example कि she said कि parents आते हैं कि पहले तो blah blah किया, then suddenly they vanish. So this is how again you have to take detailed history of any problem during the birth or after the birth. Childhood illness or injuries, infections, head trauma and all, and again uncommon in some cases, which is idiopathic. We don't know the basic why it's happening. How it is diagnosed? Again, IQ testing. Typically, IQ score should be below 70. Assessment of adaptive function. There are various scales to measure this. Every child psychologist or psychologist have their own favorite scales. Developmental history and delays, psychological and medical evaluations by a trained doctor is also a must. In Indian setting, it should be a combined. A doctor should be involved, a psychologist, a caregiver, and the parents. Parents को सबसे पहले ऊपर लाओ. Because हमारे पास there are a lot of children coming and their first reaction is, मेरे बच्चे में तो ये नहीं है. How did you see this? Why did you say that? Don't tell them. Send them to the highest center possible in your mind. कि जाओ आप वहाँ पे diagnose करा के आओ. Once they are gone there, when they come back to you, you have won them. Then they will listen to you. But एक initial reaction will be, they will start hating you immediately. Diagnosis must consider both intellectual and functional limitations. Key mental health needs which we need is emotional support. Children need opportunities to express themselves through speech, play, or art-based therapies. In your daily practice, you will see, but I believe when I was working, play therapy was the key point to non-verbal children. You have to carefully observe. You won't get it in first 10 or 50 patients. 51 patients you will come to know what they are trying to say by play therapy. So you have to really master it. Routine and structure. Predictability can help reduce anxiety, especially for children with ASD or sensory sensitivity. Talk to them. Ask the parents, the siblings of the child, how to talk to them and treat them. Social skill building, which you all do the best. Structured peer interaction and guided play can help them. As I said, take them out, take them to a movie theater, take them to the various public gardens, take them to the swimming pool, let them feel we are not deprived of any regular activities what my sister, a normal sister or my normal brother does. Supportive education, inclusive classrooms with trained staff reduces anxiety and promote healthy self-esteem. Next. Approaches to supporting mental health in such children are multidisciplinary care, pediatrician, psychiatrist is missing here, child psychologist, occupational therapist, speech language therapist and educator should all collaborate. In such cases, I do daily practice and we have a team approach. As a doctor, as a clinical psychologist and the trainees, we do a vast assessment because once we are diagnosing a child, it is sometimes it's offended also. Okay, how did you? But the more the thorough investigation goes into it, they might not challenge your diagnosis. Therapies, you are again the best at cognitive. You have to choose what therapy suits the best and what modality of the children and the price. The financial part of the parents. Parent training and support is the key point, because again the parents get exhausted within 1 or 2 years of successful training to a child. They've come to us कि साहब अब मेरे से ज़्यादा नहीं हो पा रहा है. That is majorly the financial issues, because we know that the training they have कि हमने training ली, बच्चे ने बहुत अच्छा किया, but there is a sudden dip when the training stops. So please, parent training should be given to them. Conduct their own classes. उनको भी train करो along with the child so they can carry on later. Medication if needed, let us decide that, but in certain cases we have बच्चा बहुत violent होता है, which is not the violence can't be taken care of just by counseling or this thing or punishments. So we have to use medications, and medications do give beautiful results initially, and then the training takes over. So next slide. Environmental modifications, if needed, should be done in school or the home, where we have the most friendliest approach to such children. Next slide. Practical strategies for support. Build inclusive school environments and anti-bullying programs. Currently there is a child with us. He's at a normal school, but his articulation is the problem, where he is laughed upon. So when he approached us, what will be your first aim to get rid out here? His anxiety, his depression, that people are making fun of me. So that's how you have to think. You are normal. There is a slight problem. Be truthful. There is a slight problem in your articulation which can be corrected. The child will try to correct it as soon as possible. Train with as many as possible caregivers in positive behavior support and emotion coaching. यहाँ पे पेरेंट्स, सिबलिंग, ग्रैंड पेरेंट्स सबकी ट्रेनिंग होनी चाहिए. इंटीग्रेट सेंसरी अकोमोडेशन एंड प्रेडिक्टेबल रूटीन्स. कोऑर्डिनेट interdisciplinary care, that is medical, mental health and educations in all forms. Plan early for transition to adult services and vocational supports, which I was talking about, that in Western countries vocational support is a must. And in my practice even we tell the parents कि इसको छोटी दुकान करके दो. So they feel better. Unki dignity, they earn dignity through that I am working. So that after the training, everything, the vocational, shuru se start karo. A little part of your therapy should be vocational also. So by the time they need, it will take time. It will take 3 to 5 years for that vocational training to happen. But you have to start. Next. Conclusion. Supporting the mental health of a child with development disability requires recognizing internal vulnerabilities, addressing external stressors, building protective environments at home, school, and in the community. Next. Next slide. Thank you.
Thank you, sir, for your thought-provoking and enriching talk. Your eloquence and depth of insight have truly elevated today's session. Now we break for lunch. We have to go on the first floor. Jeeman is the name of the restaurant. And please carry your coupons with you. We have a session post-lunch as well. I request all the CRR participants to sign their attendance for the next session as well. Thank you.
If anybody who is a CRR participant has not signed in the attendance, please make sure that you do it. Just come to the front stage and ensure that you have marked your attendance for your CRR points to be noted. I repeat, participants who have their CRR number, please make sure that you have marked your attendance. Thank you. Have a good lunch. Please report back within half an hour so that we can continue with the later half of the workshop. Thank you.
Like that is one of the biggest reason that they are not able to complete their homework. Once they start the task and they shift to the another task very easily. So that is one of the thing. That is reason that they sometimes score poor in the classes, not able to complete their homework. And I would say these are the 3 symptoms of your ADHD which you can see. If parents are saying कि घर पे तो ठीक है, ऐसा कुछ नहीं होता, the only teachers are complaining this thing. So are you going to consider it as a case of ADHD? It's a question from my side to you. If the parents are saying to you कि we just came to you because मम्मी पापा because इसके इसके टीचर्स बोलते हैं कि ये स्कूल में ये सारी चीज़ें करता है, ना टिक के बैठता है, ना किसी को काम करने देता है, ना टीचर्स की सुनता है, लेकिन घर पे तो हमें ऐसा कुछ लगता ही नहीं इसके साथ. So for the diagnosis of ADHD, it is very necessary the symptoms to be present at least more than 2 settings. If it is present only in the one setting, then that is not ADHD. Look for something else. It might be any other issue because of which the child is facing difficulty in the school. Maybe sometimes they just get a change of the school, so they are not able to club up with their peers, or sometimes they are just very restless at the schools due to multiple factors, not able to do the homeworks, or just not enjoying the school. And sometimes they do not try to interact with the others because of their poor communication skills also. So just look what exactly is happening in the whole. So what are the causes of ADHD? It is one of the biggest question which the parents ask to you. Definitely genetics plays a very big role. Heredity has its own impact. Many of the times if the parents are having any form of psychiatric illness, not even ADHD, any other form of psychiatric illness, that can manifest any form of symptom in the child. You cannot say कि आपको तो parents cannot say कि अच्छा हमारी तो depression की history, how is it possible to have the child ADHD? Yes, they can have. So आपकी अगर कोई भी साइकेट्रिक इलनेस की हिस्ट्री है फैमिली की, तो देयर आर 60% चांसेस दैट द चाइल्ड इज गोइंग टू हैव समथिंग. Another is due to structural differences. That's why we are calling it a neurodevelopmental disorder. There are structural differences also. There is a abnormality in the prefrontal cortex, basal ganglia. Prefrontal cortex is more of your responsible for the executive functioning, and that's why they face difficulty. You will see, always try to see your ADHD child. You see कि जहाँ पे भी multi-step task होगा ना, वो कर नहीं पाएंगे. That is because of the lacking of executive control. Another is your basal ganglia. Basal ganglia is for the motor movement. मोटर मूवमेंट के लिए रिस्पॉन्सिबल होता है, एंड दे फेस डिफिकल्टी विद दैट. एक जगह बैठते नहीं है, इधर उधर मूव करते हैं. सो दिस इज बेसिकली देयर बायोलॉजी बिहाइंड दैट. मैनी ऑफ द टाइम्स दिस क्वेश्चन हैज़ बीन आस्क्ड. Apart from that, environment also plays a very big role. That is what happened during the pregnancy, prenatal exposure, intoxication of alcohol or any other form of drug. Can we go to the next slide, please? Okay, so these are basically, next slide, please. These are basically the causes of ADHD, but behind the behavior, there are some other symptoms also which you can see in the form of emotion, in the form of impulse, and in the form of executive dysfunction. Like they have executive dysfunctions, and it is very well mentioned in the research also. They have a problem with the working memory. It's very difficult for them to hold the information in their mind and like remembering a multi-step instruction. They have a problem with the cognitive flexibility. They can't go to the next step so easily. They are very rigid with one way. So if you are making them to go to the another type of way, so it becomes very hard for them to accept. Emotional dysregulation is there. Sometimes they are very easygoing, and sometimes they become so irritable, very low frustration tolerance. So these all are the features of your ADHD only. And because of that, what happens in your day-to-day life, they have a very I would say conflicts with their partner. Many of the times they have a conflict with their partner. Sometimes they just fail in the academics. Okay, it has not been mentioned in research anywhere that if the child is having ADHD, they are going to have a compromised IQ. No, actually ADHD affect the capacity of the child, but you cannot say कि IQ कम ही होता है. Sometimes वो इतना ज़्यादा एक्टिव होता है बच्चा, फोकस नहीं कर पा रहा होता है, and that becomes the reason कि वो स्कोर नहीं कर पा रहा होता. It has nothing to do with the cognitive capacity. Can we go to the next slide, please? So there is a new diagnosis nowadays which is emerged out, that is adult ADHD. So what adult ADHD looks like when the symptoms of ADHD continue to the adulthood. एडल्ट ADHD का मतलब ये बिल्कुल नहीं होता है कि सडनली एट द एज ऑफ 18-19 ईयर्स दे आर कमिंग विद द सिम्टम्स. यू विल सी कि बचपन से ही दिक्कत थी. The symptoms were continued since the childhood, and now they have become prominent, and now the patient has become so much aware कि he has an awareness कि okay, so this is a problem. It is something something which needs awareness. So that is the core symptoms. Inattention, they face a difficulty in sustaining focus, disorganization, impulsivity, and emotion regulation. I would like to give the example of one of my patient with adult ADHD. He was doing MBBS. So this is giving a very clear indication they have a normal IQ. He was doing MBBS, never diagnosed with ADHD ever. So he came to me with a chief complaint कि I am not able to focus on one task. So if I have to go for an exam na next day, तो what I do is I never fall asleep, because मुझे पता है अगर मैं सो गया ना तो मैं उठ नहीं पाऊंगा. And even if I wake up, I do not know कि how much time I need to complete my morning hygiene. So if someone is doing MBBS and still वो उसको executively पता ही नहीं है कि how much time it takes, बोला that's one of the reason कि मेरी attendance कभी पूरी नहीं हुई है आज तक. मुझे पता ही नहीं है मुझे कितना time लगने वाला है. So this is my concern, and apart from that I always lose the things which is your I would say hyperactivity also, कि आप जगह जगह manipulate कर देते हो चीज़ों को, भूल जाते हो. Like in the session he left his iPad. उसको याद ही नहीं रहा कि वो आईपैड लेके आया था. सो ही टोल्ड मी कि अगर कोई आपके लिए एक टास्क है तो वो मेरे लिए टास्क नहीं है. फॉर एग्जांपल इफ़ माय मदर इज़ सेइंग मी कि किचन में जाके खाना लेके आओ, तो मेरे दिमाग में इतनी सारी चीज़ें आ जाती हैं. ओके, सो नाउ आई हैव टू गो टू द किचन, टेक अ प्लेट, फिर उसके बाद मुझे फ्रिज से खाना निकालना है, फिर उसे गर्म करना है, फिर मुझे प्लेट में डालना है, एंड देन मुझे फिर से फ्रिज में खाना रखना है, और उसके बाद मुझे स्पून लेनी है. सो आई गॉट कन्फ्यूज कि मैं कोई स्टेप भूल ना जाऊँ या आगे पीछे ना हो जाए. It looks like a very simple task, but for them it becomes a multi-step instruction, which what it is telling. It is telling a problem with the executive functioning. Executive deficits clearly indicate कर रहा है वो आपको. So yes, अगर आप न्यूरोसाइकोलॉजिकल प्रोफाइल देखोगे इन द एडल्टहुड तो आप देखोगे हाँ डेफिसिट्स होते हैं. हम न्यूरोसाइकोलॉजिकल प्रोफाइल पे मैं इतना एम्फेसाइज क्यों करें? क्योंकि IQ नॉर्मल है, कुछ पर्टिकुलर रीजंस की फंक्शनिंग डेफिसिट कर रही है. शायद एग्जीक्यूटिव कंट्रोल थोड़ा सा पुअर है, कुछ लोगों में लर्निंग एंड मेमोरी का हो जाता है. सो यू हैव टू लुक के डेफिसिट्स कहाँ हो रहे हैं, एंड देन ओनली यू कैन मूव फॉर द कॉग्निटिव रीट्रेनिंग. अदरवाइज इट बिकम्स वेरी डिफिकल्ट फॉर यू टू स्टार्ट विद अ ट्रीटमेंट ऑल्सो. नेक्स्ट स्लाइड प्लीज. So sometimes misdiagnosis happen, which happens every time and in every case. Sometimes your symptoms like anxiety symptoms are mimicking ADHD, like they have a racing of thoughts, restless, and we consider it as a hyperactivity. So you have to see when these symptoms started. Persistent symptom matters a lot because the symptoms are persistent. Sometimes bipolar disorder, because in the bipolar also impulsivity is high, distractibility is high. So it matters when it started. If you are talking about the childhood disorders, one of the things which matters the most is when it started. So when you are in the hurry to make a diagnosis and you jumped to a misdiagnosis, it is going to have a very serious implication for your client. Next slide. This is one of the trend nowadays. I saw it on Instagram. मैंने Instagram में देखा था ADHD ऐसा ही होता है, मैं भी नहीं कर पा रहा हूँ. So when you see it on the social media, it has benefits, no doubt. It increases the awareness, reduce the stigma, but it also leads to over identification. They are not able to go to the other things. If the Instagram and social media will be able to provide the therapy and diagnose the person, then definitely there will not be any need of a mental health professional. So the misdiagnosis has its own implications, serious implications. Sometimes it delay the proper treatment also. वो उसको adult ADHD मान लें, पर वो तो था, that was a symptom of bipolar disorder, और treatment time पे नहीं हुआ. What it is going to do? It is going to it is going to make a person symptom more worst क्योंकि treatment on the time नहीं हुआ. Next please. So the management, what sort of management you can apply for the ADHD? CBT can be applied for the organization and emotion regulation. Cognitive retraining you can do the adults. If you are talking about the adults, for the like in attention you can go for the grain sorting technique. For the executive controls and everything also you can use some form of I would say response inhibition techniques and other things. And with that, if you are dealing with the child, then parent and teacher training programs are very very necessary. You have to educate the parents about the things, and then you can start the behavior techniques. In behavior techniques, token economy works very well. Initially when the token economy was initiated or established, that was made for the inpatients, the patients who used to be admitted in the hospital, but now we apply it everywhere, so that works very well. You can take the behavior, challenging behavior which you want to modify, and that you can relate with a reinforcement which helps eventually the person to improve. So that can be used. Apart from that, I told you grain sorting and positive reinforcement can be used, and the contingency management, that helps very well. Like you are implying the positive reinforcement, but along with the positive reinforcement you are using a negative reinforcement also when the behavior have not been met. Okay, next slide please. Next is your ODD, oppositional defiant disorder. Next please. So there is a difference between disobedience and disorder. If a 10-year-old child is coming to you and the teachers are complaining that he has a tendency to back to the teachers, often blame others for their own mistakes, so what you are going to do? Are you going to diagnose the person directly, I mean the child directly, or try to like attempt something else? So I just would like to say that not every challenging behavior is a disorder. It depends on the when it started, persistent. कि कैसे start हुआ, what is actually the antecedents behind that behavior. ABC analysis matters a lot. That is also your functional analysis. Antecedents, behavior and consequences. What has happened earlier and what the child did and what the consequences child has faced for that behavior. And that is one of the things which helps you a lot to go for the management also. So if we talk about the ODD, what exactly ODD is? The child is very angry, irritable, they are argumentative, always getting argumentative for the authority, going against to the authority, get annoyed very easily, not following the directions, and it must have happened at least twice in 6 months. Not any rare, like rarely kabhi bhi ho raha, then you cannot say. It matters kitni baar ho raha. If it has happened at least twice in the past 6 months, then you can look for the things. Okay, so what is happening with the child? And if I talk about the ICD-11 mein, it has been kept under disruptive behavior and social disorders. So what is making a child to go for the ODD? Next slide please. So these were the clinical features which we already discussed. It's very simple. Opposing the authority. Whatever the authority is saying, child is going against to the authority. In the ODD and CD, one of the main difference is about the severity. In the ODD, child has this much I would say understanding that they do not like hurt the other person or physically. They do not cross that moral values line. But in CD, you will see that yes, definitely the child behavior is going towards that thing. Next, please. Next, so what are the reasons? Reasons are definitely it follows a biopsychosocial model. Not this, every illness follows a biopsychosocial model. Biological factors are there, genetic loading, if the parents might be having any form of psychiatric illness, or the temperament, high emotional reactivity, environmental what sort of parenting has been given to the child. It matters a lot. What do you feel? Which is the most appropriate parenting style for the child? Any one of you? Like if you have to suggest parents, ki, okay, so there is something with the parenting style, it is linked to the parenting style, so how you are going to educate them? Because आपके जो ये behavioral disorders होते हैं ना, like CD, ODD, इसमें parenting styles are playing a very big role. सो व्हाट यूजुअली हैपन्स, आप ODD के केसेस में देखोगे कि पेरेंटिंग स्टाइल वाज नॉट अप्रोप्रिएट. फॉर एग्जांपल ईदर द पेरेंट्स वर वेरी स्ट्रिक्ट. सो वो जब बहुत ज़्यादा स्ट्रिक्टनेस होती है ना, एक्सेस ऑफ एवरीथिंग इज बैड. इन आवर साइकोलॉजी वी सी even excess of happiness becomes a problem later on. If it accumulate with other symptoms, then it becomes a case of mania, right? So excess of everything is a problematic thing. So you see ki what form of parenting they have been given. Sometimes they have been like very harsh critical comments, that you are authoritarian parenting. Sometimes parents just neglected the child, they are not much involved, that is uninvolved. And many of the times when the parents are saying permissive, they are permissively involved. Bachcha hai taking the every behavior very casually, not going for the severity of that leads to these problems. So you just have to, you cannot say directly कि अच्छा आपकी parenting सही नहीं है. They will become very defensive. It happens a lot. So do not approach them directly in that manner. Just tell them ki okay, we are going through like we are starting the psychological management, but you can also do certain tasks at the home, because we are going to see the child once a week, and that is also for 1 hour, and you are going to be with the child for 24/7. So most of the work is going to be yours. So let's make these changes at the home and see what the result is coming. So that is the role of your environment, marital discord, low socioeconomic status, exposure to trauma, these all the things, psychological risk factors, poor attachment during the childhood. Maybe any other reason, maybe there was some discord in the parents, or there was a sudden shift in the child, like the child shifted to some, it has been seen very easily कि बच्चा नाना नानी के पास या दादा दादी के पास शिफ्ट हो गया था, पेरेंट्स के पास नहीं था. तो वो एंशियस अटैचमेंट तो आ गया ना, उसको सेपरेशन एंजाइटी तो आ ही गई बच्चे में. सो सोशल रिजेक्शन, पीयर कॉन्फ्लिक्ट्स, बुलिंग हुई है स्कूल में बहुत ज़्यादा. सो कहीं ना कहीं बिहेवियरल मैनिफेस्टेशन ऐसा हो चुका है बच्चे में, स्कूल रिलेटेड ट्रॉमा. And when the child has these form of behaviors, there are very high chances that they involve into the substance use also. These form of behavior, substance use and pornographic addiction, it has been seen very clearly. So do try to explore this area. That is one of the thing which is making them more prone for the behavior addictions. So interactive model is like stress diathesis model. So what exactly stress diathesis model says, when your biological factors correlate with the psychological vulnerability. अगर किसी भी इंसान की कोई biological factors हैं, like having a history of any past psychological illness, or maybe the parents are having this form of history कि parents में या family में कभी illness रही है, तो there are very high chances कि if they are going to any form of stressful situation, then they are going to face difficulty. I am not saying कि वो proper उसको problem ही आ जाएगी, disorder बन जाएगा, but coping skills थोड़ा सा affect होती हैं. So you should look for this factor and tell them about this. Next slide please. So prognosis and development. Prognosis, if you are not giving an diathesis, this is a model which is known as a stress diathesis model. Basically this model implies that if someone is having a biological foundation for psychological disorders, then they have a poor coping skills. There are high chances for them become more vulnerable for the psychiatric illnesses whenever a stressful situation will become. उनकी stress को handle करने की coping जो strategies होती है हल्के से decline रहती है. So this is the model and that is one of the reason आप OCD के cases में देखोगे patient बड़े अच्छे से improve कर जाता है, लेकिन I still having a patient, तो she improved very well, लेकिन एकदम से दोबारा एग्जाम्स आते हैं ना, वो थोड़ा सा उसको दिक्कत होने लग जाती है. एंड शी ऑलवेज कम्स टू मी एंड आस्क. सो दिस इज द रीजन, बिकॉज यू ऑलरेडी हैविंग अ बायोलॉजिकल हिस्ट्री, तो आपकी जो चीज़ है वो जीन्स में आ ही रही है. एंड थोड़ा सा भी स्ट्रेस आता है तो उसको हैंडल करने की जो कैपेसिटी है दैट स्टार्ट्स गेटिंग कॉम्प्रोमाइज्ड. डजेंट हैपन विद एवरीवन. इफ समवन इज हैविंग अ गुड कॉपिंग स्किल्स तो वहाँ पे होने के चांसेस थोड़ा सा कम हो जाते हैं, बट इफ समवन इज हैविंग अ मतलब पुअर कॉपिंग स्किल्स तो डेफिनेटली emerging the illness becomes, the chances of emerging the illness gets high. Sorry? Any age, yeah. It is not something which is age related thing. Yeah. So the prognosis depends on the your child is not getting treatment, then ODD converts into CD. As I told you, it is about the severity. The severity gets high, it converts into the conduct disorder. Even there are very high chances for ODD to convert into the antisocial personality traits also if it is not treated on time and treated adequately. So that is the main, I would say, the reason of taking the treatment. Next slide. Management, basically parent training management, that matters the most. I always emphasize on one thing when I teach to my MPhils ki if you are dealing with above 18, your most of the work is like limited. Why it is happening and what is the frequency, is it a persistent kind of thing? Because जब आपको कोई illness होगी ना तो mostly वो persistent ही होता है. कोई भी illness ले लो, I'm not talking about the childhood disorders, let's take the depression also. Persistent and pervasive low mood होता है, situation specific नहीं होता है. In the same manner OCD में repeated thoughts होते हैं in most of the things, that's why we are saying it intrusive, कभी भी आ जाते हैं, इसे सिचुएशन स्पेसिफिक नहीं होते हैं. एंड द सेम अप्लाइज टू योर दीज चाइल्डहुड डिसऑर्डर्स ऑल्सो. मेंटल रिटार्डेशन ले लो, बच्चा हमेशा ही प्रॉब्लम फेस करता है चीज़ें करने में. इट्स नॉट सिचुएशन स्पेसिफिक कि घर पे कर ली, स्कूल में नहीं कर पा रहा है. दे फेस डिफिकल्टी एवरी टाइम. नेक्स्ट स्लाइड. सो it's not defiance, it is about persistent, pervasive and impairing. If you are making a diagnosis, if you are starting a treatment, just look for these three factors. Is it persistent या हमेशा रहता है? Is it pervasive or is it a impairing kind of things? Repetition, severity and impact on functioning. Functioning is supposed to be age appropriate. Like if it is a child, it is going to be related to this home, school and peer relationships. उसका कैसा रिलेशनशिप है बाकियों के साथ, सो दैट मैटर्स. नेक्स्ट वन. सो हाउ दिस डिसऑर्डर केम्स, एकदम से हमारा डायग्नोसिस नहीं आया था कंडक्ट डिसऑर्डर का. In the early views, before the DSM era, it was considered as antisocial behavior and it was seen as, I would say, the bad kids. So it was considered as a juvenile delinquency. उस टाइम पे conduct disorder was seen as a juvenile delinquency. उसके बाद आपका DSMs आए. DSM सेकंड में भी क्लियर डायग्नोसिस नहीं आया कंडक्ट डिसऑर्डर का. DSM सेकंड तक भी इसको एज अ एंटी सोशल बिहेवियर इन चिल्ड्रन, क्योंकि आपने देखा होगा अगर ODD ट्रीट ना हो तो इट बिकम्स एंटी सोशल पर्सनैलिटी ट्रेट्स इन एडल्ट्स, उसके अंडर रखा था. सो वंस द DSM थर्ड कम इन 1980, the term conduct disorder was introduced. Before that it was a struggle only. कभी वो जुवेनाइल डेलिक्वेंसी के अंडर रखा जा रहा था, कभी वो एंटी सोशल बिहेवियर्स रखा जा रहा था. देन अ प्रॉपर डायग्नोसिस ऑफ कंडक्ट डिसऑर्डर केम. नेक्स्ट वन. So what it is, the core symptoms is aggression. The child has a lot of aggression, either to the people, to the animals. So you will see parents usually come and tell कि पता नहीं इसको इतना गुस्सा क्यों आता है, जानवर होते हैं ये लेके बेल्ट मारता रहता है. So they have a lack of empathy. They are not able to feel the pain of the other person. So because of that, there is a very high aggression to the people and animal. Sometimes they even, because of that high aggression, commit the crime also. That is also the factor. After that, property destruction. किसी की bike खड़ी है, गिरा दी, and sometimes they even set it on fire also. These form of behavior. They are the extreme behaviors. I told you initially also कि यहाँ पे जो आपका societal norms होते हैं ना, they are violated. जो आपके जितने भी मॉरल वैल्यूज, सोसाइटल नॉर्म्स, वो सारा वायलेशन होता है. और यही एक कारण है कि बहुत लंबे टाइम तक इसको जुवेनाइल डेलिक्वेंसी के अंडर ही रखा गया था. थेफ्ट, चोरी करना. सो अगर पेरेंट्स आपको बोल रहे हैं तो एज बीइंग अ साइकोलॉजिस्ट आपका एक ये दिमाग में भी आ जाना चाहिए कि वाई द चाइल्ड इज इन्वॉल्विंग इन टू दिस बिहेवियर. चोरी से फ़ायदा क्या हो रहा है? मैनी ऑफ द टाइम्स दे जस्ट ट्राई टू स्टील द मनी टू engage into the harmful behaviors, maybe just पैसा चोरी कर लिया सब्सटेंस खरीदने के लिए. In a very young age they start consuming the substance. Or sometimes a lot of increased use of pornography leads to a lot of not suitable and abnormal behaviors also. Yes? Yeah. Not audible. OCD देखो, कॉमॉर्बिडिटी तो कभी भी किसी की भी आ सकती है, बट यू हैव टू सी ना कि इज इट इवन अ OCD. OCD का तो क्राइटेरिया ही पूरा डिफरेंट है. रिपीट, yeah, they have aggressive sexual behaviors. OCD का पेशेंट डायरेक्ट नहीं इंगेज हो जाता. OCD के पेशेंट को मोरल वैल्यूज, सोसाइटल नॉर्म्स की बड़े अच्छे से नॉलेज होती है. दे ट्राई टू कंट्रोल इट एंड दे, आई स्टिल रिमेंबर वन ऑफ माई पेशेंट जिसका ये भी मतलब दे हैव अ सेक्शुअल थॉट्स एंड ही केम टू द हॉस्पिटल जस्ट बाय इंसिस्टिंग दिस थिंग, please admit me to the hospital, I have a fear, what if I engage into this behavior outside into the society, because my thoughts are so repetitive that I am not able to control them. So they have this awareness, they actually know ki what is suitable, what is not suitable. They have that empathy, but here that thing is missing. So that's why the functional analysis matters a lot. Yeah, next slide. So this is the criteria I just mentioned in the full. They are the same symptoms: bullying the others, threaten the others, or using the weapons at a very young age. They have a manipulating behaviors also. Like once you start taking the history na, the child is going to present the self in a way as if they have not done anything. Because you just have to be very careful ki okay, this is also a part of conduct disorder to manipulate. So you have to look for the other factors also. So that is the thing. Chori kar lena, cruelty towards the animals, towards the people. Next one. And they engage into the physical fights a lot. So you just have to look for the age appropriateness. Do not imagine कि ये behavior क्यों नहीं हो रहा है. Just look कि age appropriateness है कि भी नहीं है. Next slide. Sexual activity. Forcing someone into the sexual activity. So it is also seen into this destruction of property, किसी भी चीज़ को आग लगा देना without even thinking about the consequences. I told you about the impulsivity into the ADHD. Na? I said impulsivity is a behavior that you are indulging into behavior without thinking about the consequences. So it is also a type of, I would say, impulsivity, that you are not able to think about the consequences, what can happen. You actually have high impulsivity, or I would say lack of empathy also. Serious violation of rules. You will see that there is a serious violation of rules. That's why I said it is about the severity also. The severe uninvolved parenting styles. Okay. In cases mein uninvolved parenting styles. Okay. In cases mein I still remember one of my case of conduct disorder, and when I just tried to take the history to see like actually how it happened, because as being a psychologist you mainly focus on the psychological formulation. हम साइकोलॉजी में ये मान के चलते हैं कोई भी इलनेस रात रात में नहीं आती है, एक्सेप्ट फॉर ATPD. देयर इज ऑलवेज अ origin फॉर एवरीथिंग. सो व्हेन आई टुक द हिस्ट्री आई केम टू नो कि parents don't want the child. They actually do not wanted this pregnancy, and after that their behavior to the child for the initial years was very uninvolved, not caring for the child and more focused towards the other child. So these things also build a form of frustration into the child, and sometimes it manifests into that in this way then. And presence of maltreatment and sometimes exposure. We always say ना behavior हमारी behavior therapy क्यों work करती है? What is the major principle of behavior therapy? That behavior is a learned. So why we are not able to accept this thing कि ये behavior भी तो कहीं ना कहीं से देखा होगा उसने. So they must have seen the form of violence at their surrounding, not in this severity, but they would have got an exposure. Next slide. So the management, in the management, it is a multi-systematic therapy. You do the family therapies also when you see that there are some dysfunctional family norms, and cognitive behavior therapy. Once you see that the child is 14, 15 years old, then we actually first try to make a very good rapport with the child and try to involve it in the behavior therapy and the parent management training program, because you cannot underestimate the family factors, what factors exactly the problem is coming from. So, yeah. Then you can use an eclectic approach. Eclectic approach means that you are using more than one therapy at a time, because you see that the problems are coming from multiple areas. So you can use the eclectic approach, like you are using the cognitive behavior therapy to deal with the symptoms of conduct disorder, and on the same time you are using the parent training management program for the home management for the parents. So eclectic approach works well in those cases. And even if you see the I would say addictive behaviors, then urge surfing, in that comes under the CBT also, they can be used very well. So next slide. So this, thank you everyone. Any questions?
This knowledgeable session made us realize that ADHD brain may not follow the usual path, but it can lead you to remarkable places. Thank you, Ms. Garima, for such an enlightenment session. Can we have a huge round of applause for her, please? We are honored to welcome Ms. Arul Selva Lakshmi and Santosh Sharma, joining us through an online session for understanding child development and cyber safety interventions. Ms. Arul Selva Lakshmi serves as the Deputy Chairwoman of the Unity of Nations Action for Climate Change Council and is a renowned corporate security expert at RTL Group. We kindly request the media team to connect us through.
Hello everyone. Can you hear?
Yes.
Let me know when I have to start.
Are we audible, Mr. Santosh Sharma?
Yes, I can hear you.
Perfect. The screen is on, so we can start with the session now.
Okay, I will share my screen.
All right.
With the slide. Let me know if you can see that.
Perfect.
it visible?
Yes, the screen is visible. Just give us a moment.
Yeah, let me know when I.
Yeah, it's good to go. You can start, sir. Thank you.
Okay. So, good afternoon, everyone. I know you were very eagerly waiting for this cybersecurity session, and now we are here. I'd like to give a small introduction about myself. I'm Santosh Sharma. I work in Netherlands in SPN as Enterprise Security Architect. I have 14 years of experience in cybersecurity, network security, information security, all those combined fields. And you might also be interested like what I am doing as part of my day-to-day. So my main role is to define security roadmaps, security strategies to assess the designs from the security perspective and review the policies. Most importantly, talk with stakeholders like cybersecurity director, CTO, etc., and also the low-level management. So today, my main purpose is not to speak a lot of technical jargons, but I would like to deliver a message back to you so you can go back and you can think. So there are only two slides what I'm going to present today. The first one is on the personal aspect, and the second one is purely on the cybersecurity. This is my thinking as a security professional, spending 14 years in this field, that security starts within you, from you. It means that if you are going to work in a cybersecurity company in future as a cybersecurity role, it doesn't mean that you will only apply the security in the company. It starts first with you, how you are taking care of your personal security. Let's take an example. When you go to McDonald's or maybe if you're visiting, you're going to hotel or you are traveling, then you are going to airport. How do you connect to the internet? Do you connect with public Wi-Fi? I'm Indian. I can understand that you would like to save some money, but that could put us so much damage to us. That could cost us a lot. So I highly recommend that we start security from ourselves first. We think, okay, what we are doing. We do not connect to public Wi-Fi wherever we are going. The second most important thing is you need to ask yourself, are you a clicker? Do you like to click on the links that you get either from WhatsApp or any other social media, Facebook, etc.? If you are a clicker, then you are really most dangerous person for yourself and also for the company because you are definitely going to give some damage to the company or also to yourself. And we know that nowadays the attack has become so much sophisticated, so much complex that we cannot really having this kind of behavior. A person can compare himself when he's clicking on the links randomly. He can feel like you are just putting your feet on the landmine. It can blast anytime. It may not, but the time will come definitely when you will end up in that game. And the next thing is social media is very important to understand that nowadays most of the people, what we are doing, we put every photo, everything about us. We give all the status where we are making food, we are going to visit somewhere in place. So we are telling attackers, we're inviting them that I'm not at home, you are welcome, you can go to my home and you can do whatever you want. So we have to be very sure. If I tell about my example, I think you might also be interested how I'm doing it. I don't have any Facebook. I'm only in LinkedIn and YouTube because I also have a YouTube channel that is purely technical stuff. So even if I have to update my profile on LinkedIn when I change a company, I do not post it because I know when I will post it, I can be a target for phishing. And a person like me, if my account is really hacked, how much damage it will cause to the company. I do not work on the tools, but if I give approvals to do things, a new account gets created. Yeah, a lot of damage can happen. So we have to be very careful on that. All the specs that I'm explaining are related to personal self. Phishing, I'm not going to, of course, explain all the different types of phishing because then it will become very technical meeting. But phishing is almost same what we just discussed. You might be getting an email and you're clicking. on that email, or you are getting social media messages, you are clicking there. So you have to be very careful that you should not become a victim of being pitched. And then most important thing is identity. How can you cure yourself? So I would not like to leave you alone with all these advices, but you should also have a measure that you should start taking from yourself. Identity is the most important pillar, most important aspect that you have to take care. When I say identity, I mean when you're logging into Facebook, your Instagram, or your LinkedIn, you should make sure at least the basic minimum security, which is called two-factor authentication, is there at least. I do not even like two-factor authentication because the world is moving to passwordless. You can see what is passwordless. You can research for that. So the people who are really on the field of computer science or are thinking to go for cybersecurity, they can explore more how the passwordless things work. So whatever I try to explain from this first slide is security starts within you, from you. There is a survey where it says 56% of diabetic doctors have diabetes themselves. How would you feel if a person is too much fat and you are in a gym and he's giving you advice? You would not like that, right? You will just see him as doubt. Oh, okay, I mean, I'm in good shape and you're telling me that I'm not doing good exercise. Compare yourself same when you are in a company and your habits are not good, your personal self is not good, you're being hacked. How a company could see you as a security professional. So everything starts from our personal self. How do we treat security? The next slide is on the risk management. So risk management is also you can apply in your personal life for sure. But I would like to keep it from the professional perspective whenever you will join a company. Being cybersecurity expert, you might be reading the standards, NIST, ISO, etc. However, these standards teach you that you have to do risk assessment when you join a company. That is not the most important thing that you have to do, as per my experience, even though these standards are teaching you that. The most important thing that I do, at least when I join a new company, is I understand the business of the company. And if you understand the business of the company, you know from where the company is earning revenue and where it can have most damage, revenue shocks when a hacker can hack. And then it will tell you what are the most critical services that you have to protect. From this whole journey, it starts that, okay, how you have to take care about your risk management. It is also important to tell you that we have a lot of risk when you join a company, but we cannot eliminate all the risk. People who also from my previous we have to take a risk. Hello. I will make this. Hello.
Hello?
Okay, I will continue. I was hearing back myself, I heard some echo, but it's fine now, I will continue. So, in real life, you have to understand that we cannot eliminate all the risk, and we have to sometimes accept the risk. We have to mitigate the risk. The most important is you have to prioritize them. You cannot say, I have to mitigate all of them. Prioritizing everything means prioritizing nothing. You have to have a plan, but you have to mitigate first. You can compare this with your daily life. Okay, when you wake up in the morning, do you have a task list? Like, okay, today I have to do 10 things in the morning, and are you really prioritizing them? Okay, these are the most important that I definitely have to do. And if you're not doing that, for sure you know that how many of them are you completing. The same funda applies in the companies when you're doing risk management. You have to make sure all of these are applied. So there was also one important message Arul please ask me to convey. And it is attached to my previous slide. I will go back there with. So it is related to fishing. Fishing, of course, understand fishing, and it's really important that you teach your child, your kids who are, you can start after 5 years of age. I think that in Netherlands, and people are sending their kids to the companies and at age of 8, and they are being told about cybersecurity. There have been hacks that happen when the kids are having phones on their hand and they're randomly clicking on the links or something, and they can end up installing a malware. So it is very important that we teach our kids also related to these things, that do not click on every top thing or ask your parents and then click it. So then I end up in the last slide. I would like to read it line by line because it's concise both of the slides. In summary, risk assessment gives us direction, but in real life, in real world, your adaptability and understanding of business reality defines your success in cybersecurity. Just like social media rewards the brain, like your dopamines are getting released, whatever you access, your Facebook, etc., posting all the images, real world secure rewards come from habits, not checking. Thank you.
Thank you so much, sir. Now I request Ms. Arul Selvalakshmi to please kindly take over the session.
Just a second before I share my screen. Could someone open up my screen as well?
Yes, ma'am, it's okay.
Perfect. So, everyone, students, faculties, management, and distinguished guests, it's been so young faces in my lectures. So, thank you for having me. And today I'm going to talk about one of the emerging risks in the industry, which is AI risk and deepfakes. And we will dive into this. So, before that, let me give a short introduction about myself. So my name is Arul Selvalakshmi, and I'm originally from Chennai, India. And right now I'm a corporate security expert in a European media company here in Germany. And I have about 13 years of experience in the field of corporate security, cybersecurity, and I have a master's in information security from the University of Graz, and currently pursuing my international law degree at the University of London. And it's not a new topic, right? Because from the theory that we are learning. It's out there in the market, it's no longer for military purpose only, it's also for commercial, and it's right there in your hands, in your mobile phones, in the website, in social media that you're all using today. And so to give some technical introduction about what is machine learning, I will keep it simple for the common audience. So machine learning, this is the most common form of AI. And the one behind most of the smart apps that we use today. And it's about training machines to learn from data and make decisions without explicitly being programmed. Like we no longer have to write a huge program, and instead we tell the machine how it can teach itself. So that is machine learning. And natural language programming is also, I'm sure we all have interacted with Siri, Alexa, ChatGPT. So this is the base of how these applications work behind with natural language processing. And computer vision is how AI understands things. And now we have the language processing as to tell how it processes things. Now vision is something that helps AI to understand the world through image and video. And let's say that we give ChatGPT a picture of a cat. It can tell that it's a cat. And it uses computer vision in order to do this. Basically, it's AI with eyes, I would say, and it's getting really good at seeing what we don't. And deep learning, of course, this is the tiniest form of AI, and it mimics our own brain. And this is a very crucial thing, and this is where we are marching towards right now. And deep learning uses neural networks, and it's like artificial neurons in human brain, let's say, to process complex patterns. And when ChatGPT was first, OpenAI released ChatGPT for the first time, it did not have as much of intelligence as it has today. And in just 1 to 2 years, you can see that. I'm sure that when ChatGPT got launched, all of us wanted to use it, see what it can do, and we were surprised of what it can do for us. But now it is improving every day. And here deep learning is what majorly contributes to this factor. And a few examples of the subdivisions that we have in AI is multimodal AI that helps learning. AI just doesn't read text, it also sees, it listens, responds in multiple formats. And for example, how it can also speak. So we are talking about AI correlated with all the 5 senses of humans. And about real-time deepfakes, now this is a real problem we're talking about. Live deepfakes are a thing now, and you can do it in Zoom calls, you can use someone else's face. In the following slide, we will see more about this. And I'm sure that all of you are aware, because all of us use social media and we know how deepfakes, we have seen real-time examples ourselves. And AI agents is bots like Siri and Rufus from Amazon. So these are apps that, where you can say, hey, can you just book me a trip to Goa under 10K? So it will do its job. You don't have to do the analysis anymore. An AI companion is having AI friends. Now this is even more crazier, because it replaces our thinking process. It is able to create, replicate our senses, and now you can have an AI friend. And people who have used ChatGPT, I can tell you that some of the people have found ChatGPT to be a better friend than their actual friends in terms of giving advice, and maybe relationship advice and career advice as such. And all in AI in cybercrime. So in cybercrime, I think we are, especially as cybersecurity experts, this is really a dark twist for us. And it isn't really helping us, I would say. It is more about tricking people into digital scams and digital frauds. And where on the other side, where we want AI to help us detect these, it is a very slow progress in helping the good guys, I would say. And let's look at some of the AI's cutting edge technologies in some of the main industries. So in healthcare, AlphaFold is developed by DeepMind, a company that has cracked protein folding puzzle. Now this is a very critical part of creating drugs, to synthesize drugs. And AI is able to do this now, and this is going to help the healthcare industry to break accelerating the process of developing drugs exponentially. And we also have Google MedLab, Pat Allen. So what this does is, it's more like AI assistance in helping you get a second opinion. Now it's a second opinion because AI cannot be a replacement for humans itself. It's more something that helps to, help humans to feed information, and it has not been a replacement yet. And that is how it is being sold in the market. So that is the role that Google Med ALM, it contributes to, so where you can get a second opinion. But we all know, guys, what Google says when you ask that you have a headache or you have a migraine, you know what kind of results that Google tells us. So that's something we need to be cautious about. And in Japan and in China, people are already starting to use fully a surgery that is fully done by AI. Now we have exponential use case of robot-assisted surgeries, but now there is a groundbreaking technological advancement where the robot performs a very micro level surgery on its by itself. So this is where the cutting edge is right now. And in agriculture, we all already know that, especially in the US market, we are using crop detection systems where they fly a drone over the field and it already tries to understand where is weed and there are some bugs, and it already gives you solutions what you need to spray and what kind of pesticides you need to use. And education, importantly, we are having AI-assisted tutors now, and where it is exponentially growing in the market, where it's also able to give you, you know, courses that are personalized for you. The content would be the same, but it sees how it can, you know, personalize the methodology of how it delivers the content to you. So this is a groundbreaking things, you know, because the fact does, of course, the best job, and because they are the other person better, in the students better, and to deliver content accordingly. So now this is what AI is also trying to do, and it's going to be a great assistant for faculty as well to help understand students better in this regard. And defense and cybersecurity. I was in an international cybersecurity summit last year, which was conducted in London, and I saw some of the autonomous defense systems that was presented to the government and military clients. And one spy bots, drones that, you know, for example, China or, you know, could be any neighboring country that flies across other territories to spy on other military activities that is going on.
Media team, there is some problem with the speakers. Media team.
हटाओ मेरे हटाओ मेरा वाला हटाओ ना हेलो मेरा वाला तो हटाओ मोनो वाला हटाओ हटाओ ना
Can somebody confirm it?
Yes, sir. Now the audio problem has been solved. We can continue.
Okay, thank you. And importantly, in cybersecurity, with I look at Microsoft, companies like Microsoft is helping to build AI-based threat intelligence systems that is going to help cybersecurity folks to detect. But are we completely depending on these? No, because AI is not as advanced as what a human would do right now. So we are not depending on this, but we are using it for first level analysis or first level report in this case. Let's go to the next topic. So what is the real risk that you're facing with AI today? And I think most of you know the answer to this, that we are getting plenty of misinformation and fake news. And especially if you open Instagram or Facebook, we are getting the algorithm is doing its job, but what people are doing is just to keep us engaged. The main motive is to keep us as users or consumers engaged with our screen, to spend more time in the application, because that is what is giving revenue to Instagram and Facebook. The more the time we utilize in these apps, the more money we get. So that's why it is free for you and to keep you engaged. It's not required now that you have to be fed the right information for you to spend more time. It's any information that is going to keep you engaged is what is being pushed onto us in social media. So misinformation, we are being flooded by content every day, but now a huge chunk of it is fake and is AI generated. And it's made up news articles to political propaganda videos. It's getting really harder to tell what's real. And we also have AI that completely understands what you want, generates contents, delivers it to you, and also manages the whole package. We also have AI doing things. So if it is too dramatic, too perfect, or too oddly convenient, I would say it might be AI. And the second one is deepfakes. Of course, we spoke about this. This is one you've probably heard of: synthetic videos or audios that mimic real people, and faces that are copied, voices that are cloned, and you have a video of someone saying or doing something they never did. So probably if you're getting a call from Tom Cruise, and candidate to come in person. So how do we tackle it? So, right now we have deepfakes where in a Zoom call you can have somebody else's face, but somebody else is taking the interview. Or you have the answers to the questions, this you live on TV. So how do we detect this? So we are right now looking for solutions where we can detect these things, but comes with a bigger cost. So to build the resilience against hiring bias is a challenge right now in our market, I would say. And it's also important that you recruit, or even for students, it's important that you take students of good merit, and there shouldn't be a bias when it comes to skills and knowledge. And this is something that we are building resilience towards. And synthetic reviewers, of course, you know that there are bots and fake narratives that is there in the social media. And classrooms, of course, it's not a new topic. I shouldn't have brought this here, and but just to be mindful about things that we do. We also know that ChatGPT does most of the homeworks for students, and but it always we create a line between AI and us. Should we be in separate boxes? Of course not, because the future is not marching towards it. But how do we use ChatGPT to enrich our knowledge and to learn more to deliver is what truly matters. Because I can tell you guys, in a few years, there's going to be AI systems that is going to detect the work of other AIs. I would say it's already out there for plagiarism and things like to detect things like that. It's already there. So it's important that we use AI to enrich our knowledge and cover things that are out of our effort. Because We can always get assistance of AI, and because if we do this, we try to completely, take assessments, assignments, and things like that. It is going to take us over. Now that is the risk that we're building upon ourselves, and this is something that we should take in mind. Now let's look at some of the real world impact of AI next years. And we know that in 2024 elections, there were so many deepfake videos of Modi ji and also Rahul Gandhi ji. And this was also addressed by the PM in that time. And it is if the Prime Minister of a country can be subject to such scams, think about us. And this obviously, develop resilient mind in this case to be very cautious of what you upload to social media, and your privacy settings are very important in this case. And Bengaluru voice cam, yes, we just talked about this. And so yeah, your Instagram reels could be training data for cameras. Next call. And I will also give you some tricks of how we can avoid this, or how we can protect ourselves in the coming slide. And fake AI jobs, yeah, we spoke about this, and this is job hunting in 2025. Scammers don't even need to show up; they just deploy bots to attend interviews, and that's something that we are tackling right now. And there's deepfake news anchors. There's also AI generated statements that we look at. Let's say that there is Halsey, and I have seen several videos of hers. Now AI is able to generate a video with script that she never spoke about, and the way her journalism is exactly how AI implements it. So it's very hard to understand what is new, what is real, and what is AI fake. So I will use some tricks to identify this. And deepfake harassments on Instagram, better because women often faces being used in explicit deepfake videos, shared anonymously in Telegram groups and these dark web groups. And most of them have no idea that their selfies are being misused. Even today, most people do not know where our face is in the underground market. And also, another point is about the political bot armies, and during political campaigns or protests, social media is filled with what looks like a mass public support or outrage. In many cases, these are AI bots spamming Twitter or ads to manipulate sentiments, and what trends isn't always real, I would say, and it requires crucial analysis. Now let's look at some of the tricks as to how you can outsmart this AI. Because AI is getting smarter, so should we. And we should keep up with the game and ensure that we're always on the top of the food chain. For the 5-second what exactly is it? I would say if you're suspicious about watching a video and you do not know if this is real or fake, pause, zoom, and rewatch. And if it's a human that is involved, you can see that there is a natural breaking, and the lip would have some weird sinking, and the edges of the person would be blurry, or the light would be flat. If the person, the background, everything is going to be flat. And that is one way you can identify if this is a real video or fake. And if so also question it. If you're getting critical information from social media, question it. And if you see a shocking or emotional video, pause, zoom in, rewatch, look for off-lip syncing and things like that. Don't trust, verify. These are some of the applications that you can take note. Ingrid, it's a Chrome plugin for video analysis if this is real or fake. And let's say that there's a celebrity scandal that's coming out, and everybody wants to tell us about it. Before we get diverted, before we spend our next 3 hours gossiping about it, let's do a check that we should be mindful of not being manipulated by fake AI. And and also, I would say, even if a video is forwarded by a friend or family member, always verify it. And lock down your digital identity. You know, what you post today may become tomorrow's fate. And so limit what you share, like what Mrs. Santosh said, limit what you share on social media. Full face selfies, prominent voices, baby documents, travel plans. She's about sharing these not mic and camera permission from your apps because it's absolutely necessary. It's important that once every 6 months you need to have a digital hygiene routine where you look at your social media, your notifications, permissions, and see what you're allowing. Because a calculator now requires permission to your camera. Why? It doesn't require it, but it's requiring it because there could be programming that is done in the background where it also appear as a spy software. So we do not know. It's important that we be cautious. Valid verification trick, yes. So in older movies, when a child is lost, at least in Tamil movies, we have this where when a child is lost in the childhood, and after 18 years, they hear a song of a family member singing, and then the child goes crying, saying that, hey, this is my family song. Now, it could be funny, back then it was like, or they have a specific type of clause in the family, and they recognize that this is their family, and then they have a family reunion in the movie. Now, this is one of the good trick, I would say, because of the voice scams that's happening today. It's important that you have code words between your friends, between your families, and it's not required to use this regularly. I would say, just have something, a word, that you like to help identify to your parents that it's you, or maybe a question that only you would know and your parents would know. And it's important to have these code words, I would say, and start using it between your friends because even on WhatsApp, you're getting impersonated requests for money and for more information. Click on this link, click on that link. So it's important you have code words, guys. And screenshot test, what exactly is this? If you're not sure, screen it. Take a screenshot of the video or image, run it through reverse image search. And we saw some of the tools here like TinEye by Google, and you can use such tools to analyze if this is true or fake. So let's look at some of, importantly for psychology students here, and I want to deliver this clearly because with AI, the only firewall can build is in the mind. And in the digital world, we are here cybersecurity experts, but for psychology students who are working on human mind, if it is not digital, where does the firewall come from? I would say it should come from you. It should come from your research that you're doing, and I would also kind of request to include these aspects in the psychology of children because we, at least when I was young, is when the first computer came. When I was 6 years old, is when we got our first computer at home, and the internet was born when we were there. And children these days for the future are born with everything in the hand. They're born with all the advanced systems in the hand. And it is for us it is people to distinguish between what's AI, what's not AI, and what is internet, and because we have had all versions of technology from the beginning. But for children, they have the advancement in their hand right now. So it's important that we also see how do we build a mental firewall for them. We won't fall victim to what the technology is delivering right now in terms of risks. And critical thinking, not everyone online is real, even if it looks real. Now, it is important to teach children this, that what they see and what they are being fed, because you know that children absorb everything that is in their environment, either consciously or unconsciously. They mirror and learn. So it is important important that children today are digital natives and but not digital skeptics, I would say. So each inquiry question: who made this video? Why is it being shown to me? How am I observing this? How am I going to, these are something that children cannot, but it's important to handhold them and teach them that, hey, there is a possibility what you're watching might not be true. So help them build a questioning pattern in their ecology, and also set boundaries together as parents, as teachers, as mentors. I would say co-regulate and do autonomy building. Children need guided autonomy and not digital isolation. It's not possible that you just tell a child that, hey, don't use cell phone, don't play games, because they need the stimuli that is required to keep up with this world. So it's not possible that we isolate them digitally. So it's important to work with privacy norms and this will internalize control and not just obedience, I would say. And encourage healthy boundaries, explain that oversharing can expose them to image manipulation or voice cloning, things like that. And don't overshare children's photos on it's very important. You can see celebrities, they always put the emoji on top of their child's picture. It's because it is really important. I wouldn't say it is because of drishti, what we consider in India, that's why they're trying to hide the child's face. Spiritually, yes, but digitally, it is important that they are not subject to deep fakes in the dark webs. And parental controls, of course, I do not have to explain on this. And spot voice and video scams. Children need to be trained mentally how to spot scam and how to protect themselves and not believe everything that they say out. So with this, I think this was a useful takeaway for you guys. And do you have any questions, anybody, that I could take?
I think from a psychological perspective, AI and the risks that it poses is a huge threat. If any audience have any questions, they can raise their hands. I suppose it's a no. Thanks a lot, ma'am. It was really fascinating to know a lot about AI and the risks and how it can help as a psychologist as well. And it was really fascinating to know somebody who's from South India as well. Thank you, sir, for the session. Thank you, Santosh, sir. Thank you, Arul, ma'am. On behalf of MJRP University, we thank you for being with us and joining for the session. Thanks once again.
Thank you, everyone. Have a great day.
Thank you, everyone. Bye.
Now moving ahead, it is an absolute honor to introduce our next speaker, Dr. Manoj Kumar Bajaj, an esteemed academician, clinician, and mentor in the field of clinical psychology. Dr. Bajaj currently serves as an associate professor of clinical psychology in the Department of Psychology, University of Delhi. He is also a respected member of the Course Council Committee of Psychology at Delhi University. The next session will be on directive play therapy. Thank you, sir.
Can we have PPTs? नमस्कार खमा घणी खमा मुझे लग रहा है आप लोग खाना खा के थोड़ा सुस्ता रहे हैं, थोड़ा सा एक्टिव होने की ज़रूरत है।
मीडिया कर्मी पीपीटी लगा दीजिए सर। So my topic for today is directive and non-directive play therapy with children, right? How many of you are aware what is play therapy? Have you read somewhere? Do you know something about it? Yes or no? पीछे वाले सुन रहे हो? हाथ खड़े करो। 50% तो सो रहे। अच्छा, व्हाट इज प्ले? जब तक कि हमारी पीपीटी स्टार्ट होती है तो हम थोड़ा सा बात कर लेते हैं। व्हाट इज प्ले? कभी सोचा है? बचपन से बड़े होने तक हमने बहुत प्ले किया है ना, लेकिन हमने ये नहीं सोचा व्हाट इज प्ले। प्लेजरेबल एक्टिविटी। सो प्ले वर्सेस स्टडीज, what you like most? Every child, even still today's also, so we like more play. Why? Joy and pleasure, one thing. What else? What else? That's it. So watching a movie which give you enjoyment is also a play? No. Then why play only? That only enjoyment is not a play. It is not completing the play, right? So there is something else also. Expressive. Okay. Can you elaborate little more? Fantasies, ambitions, we used to fulfill through play. Yeah, you are reaching. Go on. Yeah. Expressing emotions through play. आपको पता है कि पिछले जन्म में आप क्या थे? नहीं पता? पास्ट लाइफ रिग्रेशन सुना है? अच्छा, उसमें बताते हैं आप पिछले जन्म की यात्रा करके आते हो ना। उसमें आप बच्चे थे, कितने बड़े थे, क्या कर रहे थे, वो नहीं पता चलता। जिस एज रेंज में आप होते हो वही देख पा रहे होते हो, आप चाइल्डहुड नहीं देख पा रहे होते। तो जो छोटा सा बच्चा होता है वो बहुत सारी एक्टिविटीज करता है, जो एक्सप्रेशन देता है। हम कई बार हमारे जो बड़े हैं, पेरेंट्स हैं, वो ये कहते हैं कि सोए सोए स्माइल कर रहा है ना। तो इसको कोई पुराने जन्म की या पिछले जन्म की कोई अच्छी बात याद आ रही है ना, कहते हैं ना। युंग ने इसको कहा कलेक्टिव अनकॉन्शियस। सो वी आर कैरिंग फॉरवर्ड अवर प्रीवियस इमोशंस, प्रीवियस फीलिंग्स, एक्सप्रेशंस into our present life. Freud said we suppress our emotions and our feelings, our anxieties, and that leads to certain kind of fixation in particular stages, and that lead on to particular behavioral pattern, which we sometimes don't know. And he wrote a book, Psychopathology of Everyday Life. Are you getting? So I'm just linking it to the psychology. Although I have a very comprehensive outline for today's presentation, but unfortunately I'll not get much time. Likewise, in the last time also when I came, I was given the opportunity to in the last, and I have to run up. So that is one of the opportunity that they will be keep calling me, you know. So stuff is not finished yet. Yeah? So that motivates. So this is the outline, introduction to play therapy. What is play? Definition of play, play and activity. What is the play therapy? Historical development. Non-directive play therapy, situation and material, participant, therapist and parents role. 8 principles of play therapy. Directive play therapy, background and situations. Directive versus non-directive play therapies. Clinical implications, ethical issues and summary. This is the broad outline. Next slide. So starting with one case study. If you will recognize this case, which is this case, I'll ask audience to clap for them, right? So who can recognize what is this case after reading? Name, Dibs. Presenting issues, emotional withdrawal, non-verbal behavior, social isolation, suspective developmental delay, and background information. Dibs comes from a highly educated, affluent family in New York. Parents reports erratic behavior, refusal to speak, and violent outbursts. Teachers observes advanced cognitive abilities but extreme social withdrawal. And initial assumptions was possible intellectual disability or autism spectrum disorder. Can you recognize this case? What is this case? Have you heard about this case? Who is that? Raise your hand. Who knows this particular case? Dibs. Pseudonames. So this is showing that your knowledge about play therapy. So the starting of play therapy starts from this case. Dibs. There is a novel called Dibs in Search of Self by pioneer, founder of play therapy. Who is the founder of play therapy? Anybody? Virginia Oxlin in 1967. So, next slide. So I have removed what therapeutic approach they have used. She was using therapist VA, and the method was used non-directive play therapy. And setting was weekly sessions in a dedicated playroom at the Child Guidance Center. Core principle used were unconditional acceptance, child-led sessions, empathetic reflection, no interpretation or direction from the therapist. And observation during therapy, early sessions was Dibs is cautious, silent, and explores the room tentatively. Symbolic play emerge, bullying dolls, burying dolls, locking doors, painting emotional landscapes. Gradual verbalizations were begins, expressive angers, fear and confusion. Emotional themes were resentment towards father, longing for internal affection, fear of abandonment. So these were the observations in this case. And what was the progress in that particular case? So Dib transitions from infantile behaviors like sucking a bottle to mature emotional expression. And the begins initiating conversation, expressing love and showing empathy, and demonstrated high intelligence, color theory, philosophical question, and coded messages. So the child which was suspected to have autism spectrum disorder or intellectual disability, later on, after the play therapy, came out to have IQ of 169 and became normal in his functioning. So this is the magic of play therapy. Next slide. The final session, which was concluded, breaking the bottle, visiting a church, expressing existential curiosity. And the family dynamics were changed from mother initially detached, later became emotionally engaged, and the father remains emotionally distant but less critical over time. And therapy indirectly influences parental reflection and behavior. What was the outcome? DIPS became socially engaged, emotionally articulated and confident. Teachers' reports improved classroom behavior and peer interaction. Long-term follow-up described as morally courageous and intellectually thriving. And the training takeaway was the importance of creating a safe, non-judgmental space for children, power of symbolic play in revealing emotional truth, therapist's role as a reflective mirror, not a director. And early intervention can dramatically reshape developmental trajectories. So this was the take-home lesson from this particular case. I must recommend, if you want to work in this area, you must read this novel. This is a best-selling novel, DIPS in Search of Self, by the author, Virginia Oxley, right? So you must read it. I brought this book when I was doing my MPhil first year from IBHAS in 2005. I went to Daryaganj, Delhi, Sunday market. I brought this novel in 10 rupees. Although many other novels also brought, but this was the novel I brought in 10 rupees and I read in very first night completely and was very interested and was very feeling competent, motivated, encouraged to do such kind of work with children. And that reduces my biases about the children with disability, the children normally or not normally or atypically developing children, and what is their capacities. So that shaped my mind in a different way. So that opened my eyes towards that particular phenomena. So this one beautiful book, that is why people used to say this is the very landmark work by the Virginia Oxley, right? So the next slide. So you must read this novel if you are putting or you are want to understand. And I read this book and I started reading the chapters. There was no progress in beginning of those sessions. Therapist was not welcomed. But therapist used to sit quiet, just observing. She was observing for so many sessions initially. She kept patience. She didn't direct it. And what is happening nowadays? You can't even just tolerate for 5 minutes. Until unless such kind of workshops are happening, you are not silent. In workshops, you usually stay silent, right? But many times we don't. You know? In other settings, we don't. So now coming to the basic aspects, what is play and what is the definition of play? As I started my questioning, right? So play is a spontaneous and active process in which thinking, feeling and doing can flourish since they are separated from the fear of failure. कभी देखा है कि बचपन में जो हम खेल खेलते थे उसमें हार भी जाते थे या फेल भी हो जाते थे तो उसका बड़ा दुख मना के और फिर उसके बाद खेलना छोड़ देते थे. हम फिर से 5 मिनट के बाद फिर लगते थे, फिर खेलने लग जाते थे, है ना? अभी कोई कुछ थोड़ा सा कह दे उसके बाद तो बात ही नहीं कर सकते, है ना? लेकिन बचपन में हम खेलते रहे. हम अपना बचपन भी याद करें तो हमें समझ में आएगा बहुत कुछ हम कैसे थे, राइट? और डिजास्टरस कॉन्सिक्वेंसेस, खेलने की वजह से मार पड़ सकती थी लेकिन वो डिजास्टरस नहीं है. किसी को याद भी नहीं रहती वो मार, है ना. सो व्हाट इज डेफिनेशन ऑफ प्ले? इंट्रिंसिकली मोटिवेटेड बिहेवियर. इट इज नॉट एक्सटर्नली मोटिवेटेड, इट इज इंट्रिंसिकली मोटिवेटेड. ये आपके अंदर से आता है, आपके अंदर से ही वो उठती है धुन खेलने की, है ना. कितना ही रोक लो, कितना ही डांट लो, कितना दरवाजे बंद कर दो, कितना ही कॉन्ट्रैक्ट, बिहेवियरल कॉन्ट्रैक्ट कर लो उनके साथ, नहीं, निकल जाते हैं, फिसल जाते हैं, सरक जाते हैं, खिसक जाते हैं. अटेंशन टू मीन्स रेदर देन एंड्स. सबसे इंपॉर्टेंट, आजकल हम आउटकम ओरिएंटेड है, बट उसमें हम आउटकम पे फोकस नहीं करते, हम उस प्रोसेस पे फोकस करते हैं. ये बहुत अच्छे लेसन हैं. अगर आप अपनी वर्क में भी, अपने जॉब में भी और अपनी एजुकेशन में भी एक इस तरह की फीलिंग ले आएंगे ना, तो आपको एग्जामिनेशन एंग्जाइटी नहीं होगी कभी. बड़ा सिंपल है. आप आउटकम, गीता में भी यही लिखा है, फल की इच्छा मत करो, कर्म करते जाओ, फल की इच्छा मत करो. तो इसीलिए शांत है ना, आसक्तिहीन है ना, मतलब उसके साथ किसी तरह का अटैचमेंट नहीं है आउटकम के साथ. तो इसी तरह से बच्चों का मन भी ऐसा होता है, बच्चे भगवान का रूप होते हैं ना. फिर प्ले इज फोकस्ड ऑन प्लेयर्स, नॉट ऑन द ऑब्जेक्ट्स. द अल्टीमेट इज, वी जनरली थिंक ऑब्जेक्ट्स आर द प्राइम इंपॉर्टेंस. नो, if you remove one object, they will bring some other object. If you remove other object, they will bring something else. Even that they don't have object, they will still play. They will verbalize with themselves. They'll look themselves, they will talk to themselves. है ना? They'll keep jumping, they will keep running. है ना? They will keep climbing without any object. Right? Play is not literal. फ्रीडम फ्रॉम एक्सटर्नल इम्पोज्ड रूल्स, है ना. जैसे जॉब में, वर्क में, एजुकेशन में डिसिप्लिन, है ना. प्ले में कोई वो वाला प्ले नहीं जो स्पोर्ट्स करते हो. स्पोर्ट्स इज डिफरेंट देन प्ले, है ना. स्पोर्ट्स इज डिसिप्लिन, ये प्ले अलग है ना. बाउंड्रीज लेस, है ना. द पार्टिसिपेंट्स आर एक्टिवली एंगेज्ड इन द प्ले एक्टिविटी. और जो भी इस प्ले को करता है वो एक्टिवली पार्टिसिपेट करता है, एंजॉय करता है उसको. सो नेक्स्ट स्लाइड. नाउ यू अंडरस्टैंड व्हाट इज प्ले. सो प्ले इज नॉट स्मॉल थिंग, है ना. इट्स अ वेरी बेसिक इंग्रेडिएंट ऑफ योर पर्सनैलिटी, है ना. बचपन छूट गया किसी का तो वो हमेशा मिस करता है, गिल्ट होता है उसको कि मैं खेला ही नहीं कुछ, है ना. बहुत डेवलपमेंट की जरूरत है. सो डिफरेंट टाइप ऑफ प्लेज आर बीइंग यूज्ड बाय द चिल्ड्रन एट डिफरेंट एज. डिफरेंट टाइप्स आर देयर. सो 0 to 2 years unoccupied play, not engaged or actively playing with others, stationary, observing. 2 to 3 years solitary play, child play alone, paying no attention to others. Child has not developed social, physical or cognitive skills yet. ऑनलुकर प्ले 2.5 से 3.5 साल के बीच में. वॉचिस बट डू नॉट एंगेज, मे एंगेज इन कन्वर्सेशन अबाउट द प्ले टू लर्न. 2.5 से 3.5 में पैरेलल प्ले ऑल्सो दे कैन डू. चिल्ड्रन प्ले साइड बाई साइड, नो इन्वॉल्वमेंट बिटवीन चिल्ड्रन, ऑफन प्ले विद सिमिलर टॉयज एंड मिमिक वन अनदर. दे आर लर्निंग वैल्यूएबल सोशल स्किल्स. एंड 3 to 4 year associative play, child is interested in people but not in coordinating their activity with those people. Involvement but minimal interaction, no common goal, no rules to the play. जीत गए तो ये हमारा है तो है, कोई रूल नहीं चलेगा उसमें, है ना. Develop problem solving skills, cooperation and language during this play. 4 to 6 year of age, cooperative play. Children are interested in playing with others in the same activity. There is a leader and others have assigned role. And there is a group goal. This play puts together all the learning from the other stages of play. And child has learned organizational skills and social maturity here. And the self-identification with the group and the group identity may emerge. So this is what is important task during this different types of play and different stages they used to have. Next slide, please. So this is the novel which I was talking about, Dips in Search of Self. What is now play therapy? You understand play, and now what is play therapy? So play therapy is a vital opportunity that is given to the child to play out his feelings and problems, his fears, hatred, loneliness, and feelings of failure and inadequacies. This definition is given by the author of this play therapy. Next slide, please. Next slide, please. So the play therapy is based on the fact that play is the child's natural medium of self-expression. And it is a method of psychotherapy with children in which the therapist uses a child's fantasies and symbolic meaning of his or her play as a medium for understanding and communication with the child. And generally employed with the children aged 3 to 11 years of age. And play therapy is primarily of two types, directive and non-directive play therapy. Next slide, please. So the first case was elaborated by the Sigmund Freud. मैं लग रहा था कहीं मेरे लिए ही आ रहे हैं. चलो अभी तो प्ले शुरू भी नहीं हुआ था.
Before we head to the major part, we will have a photo session with sir as well. So every CRR students and others, please join in the dais so that we can have a photograph with sir, and then we will continue with the session because a lot of people have to leave to Achrol. So only CRR. So only CRR registered and pre-CRR. CRR and pre-CRR candidates, please come to the stage. Thank you. Thank you, sir.
No problem. आइए भाई फटाफट, आपके जाने का रास्ता तैयार कर रहे हैं.
यहीं पे सर,
में पीछे से लाइट ज़्यादा रहेगी,
शायद वो हटा देंगे, तो ब्लैक कर देंगे. हाँ,
बंद कर दूंगा पीछे से. नमस्कार जी, नमस्कार, कैसे
जल्दी जा जा जा, मैं बोल रहा था ना सर आपको. मेरे तो आ गए, ला रहे हैं मेरे को. आगे खड़ा सर्टिफिकेट में ले रहा है, आगे फ्रंट पे रहेंगे. जाने दो
हेलो, सेटल हो जाओ भाई सभी फटाफट। वैसे ये भी तरीका ठीक है नींद भगाने का। करें शुरू? रेडी? So, little bit of historical background. So, Freud was the one who described the first case of little hens, and you must be aware you are from the psychology background then. So, case study of little hens. Then Anna Freud, considered a pioneer of play therapy, used to help parents understand children and strive to children to constantly understand personal changes in 1928. And then Margaret Lowenfield introduced use of sand play therapy. Next slide. Bender and Waltman introduced group play therapy by using puppets in 1936. 1941 music play therapy, and 1947 client-centered play therapy influenced Virginia Oxlin, founder of play therapy. And the 1960 filial therapy by Bernard and Louis Giorne trained parents to work on play techniques with their children. Next slide. Therapy by Anne Janberg promotes healthy attachment among parents and children, incorporates concepts of self-psychology and objects of relational therapy in 1967. Then beginning of cognitive behavior therapy in 1970s, and that also included play therapy through CBT. Association of play therapy by Charles Effler and Kevin O'Connor. And the 8 principles of non-directive play therapy by Virginia Oxlin in 1989. Next. So now coming to the basic techniques of non-directive play therapy and directive play therapy. So first I will be covering the non-directive play therapy. So what is non-directive psychotherapy and play therapy? Is a form of talk therapy in which the therapist refrain from directing the client towards specific insight or solutions. Instead, the therapist provides a supportive environment, enabling the client to explore their own feelings, beliefs, and behaviors and come to their own conclusion and solutions. So here you see the therapist involvement is little bit more of a client is allowed to express their feeling, right? Is given opportunity to speak up, right? Without being judgmental or without giving any comments on their feelings. So next slide. So these are the different 9 play therapy themes which included in non-directive play therapy. Separation play, family and nurturance play, broken play, self-telling play, fixing play, power and aggression play, sexualized play, death play, and these are the some of the play therapy themes which is being covered in the play therapy, which is including non-directive play therapy. Next. So what is included in play therapy from the personality structure? So individuals strive for self-realization, independence and self-direction, but it needs growing ground to develop a well-balanced structure. And he needs permissiveness to be himself, the complete acceptance of himself by himself as well as others, and the right to entitlement to dignity to achieve direct satisfaction of his growth impulse. Next. When the individual lacks these conditions, he seems to be maladjusted. So the types of maladjusted behavior could be daydreaming. Daydreaming is a maladjustment. Nowadays, I have been observing some client having daydreaming most of the time, and they have a fictionary friends. They used to play with them in their imagination, and even then they have become 19, 20-year-old, they still can't manage to skip that. So they take out time to have that imaginary play with their imaginary friend. They kept the name. However, in initial phases, we find them having some kind of muttering to self. But later on we realize they are clearly aware that this is not in the objective space, this is the inside of their mind and psyche. And they know it is a fantasy, it is a daydreaming. But they are very, very comfortable with that daydreaming. But because of the extra time spent in that, so their socio-occupational functioning is affected. So they comes under into the maladjustments. So the day is not far that we will be including this condition as a disorder and will be treating that. But अभी कुछ केस रिपोर्ट्स हैं, है ना, अभी हमने भी ऑब्जर्व कर ली. So non-directive play therapy is an opportunity that is offered to the child to experience growth under the most favorable conditions. Most favorable play. So otherwise, in a therapy room, you bring the child, what he will be listening to you? No. All the work which you have to do with their parents. And most of the times we have to do behavior modification. Because parents' behavior learning principles we are generally using, that is more directive, instructional, education, not a therapy, play therapy kind of, non-directive. This is not non-directive. The child is given the opportunity to play out his accumulated feeling of tension, frustration, insecurity, aggression, fear, confusion, that helps him to bring out these feelings in the open, face them, learn to control them or abandon them. So during non-directive play therapy, children are expressing their feeling without any disastrous consequences, without imposed certain kind of suppression or some rules. They are freely expressing their feeling. Next slide. This leads to emotional relaxation that helps the child to become psychologically more mature and to realize selfhood. To the child, therapy is a challenge to the drive within him that is constantly striving for realization. So many times, if you consider, many time you have to diagnose a child with having certain kind of condition, so you have a difficulty in diagnosing them, because you do not know where is that thin line where we can pick up that this is abnormality in the behavior, or whether it is just a normal typical pattern of his behavior. And we have devised many tools. For example, children apperception test. So we conduct that test. We ask them to write a story on a structured content. Some is semi-structured content, and they'll write a story, imaginatory. But they may not be having that kind of structure of what happened in the past, what will be happening in the future, what is currently happening. You have to little bit conduct an inquiry on that. What the main hero is thinking, what the feeling the person is, this child is expressing, or this particular person is having. So level of identification, themas, we have to work so much on that to find out what is happening inside their psyche. The other test we use generally sentence completion test, the child version. So they have to complete the sentence. So in that also, many times we can't get much of the information, because the setting and environment may be very controlling, very biased, or very frustrating for the child. So this non-directive play therapy gives that opportunity to you. The child is free from all kind of foundations, rules, regulations. And the therapist, it gives the opportunity to the therapist to test the hypothesis, what they have assumption in their mind. For example, in that particular case, he was suspected to have intellectual disability or autism spectrum disorder. That is a hypothesis. The therapist has to test it, whether the hypothesis is accepted or rejected. It's not a statistical technique. It's a process. The Piaget has given sensory motor developmental stages, cognitive developmental stages. In that, contemplation stage gives you an opportunity to the hypothesis testing. And you see the children in a particular age, around 10, they used to experiment with the things. They used to develop certain kind of, you can say, new items, new games, something which is very, very, they try and test it, whether it is working or not, right? So this is the hypothesis kind of phenomena the experimenter or the therapist used to test whether his assumptions are correct or not. So it also gives an opportunity to them. Next. What are different situations of the participants? Next, in non-directive play therapy. Next. So now what kind of playrooms you require for that? What is the material given in that? The room should be soundproofed. So there is no external noise and external kind of stimulation there, right? A sink in the room with running water. This is also one of the object. Or you should be having because many times they used to play so much of material, they have using colors or different kind of things, they have to wash their hands. And as well as sometimes the certain kind of compulsive behaviors are observed through washing, right? So a sink with the running water. The windows should be protected by grating or screens. So nobody else is observing them, they should not be observed by somebody from the hidden side, right? So they are very firm. The wall and floor should be protected with a material that is easily cleaned and that will withstand clay, paint and water. Now, you never know what the child is going to do. So there is enough material inside the room. You cannot always have a whitewash and next day you find all vanished. Right? So there is so much of art in the room. So use certain kind of tiles which you can easily clean, right? So that kind of inner environment, inner building has to be there. Room may be wired with phonographic and recording and provided with a one-way screen for observation. One-way screen means The therapist outside that room can observe them, but the child cannot observe outside what is happening. Like in interrogation also, you have a camera, put it outside, and then you must have watched adolescents. You see that? So much of critique on that, right? So next slide. What is play material used in that play therapy, non-directive play therapy? Next. Nursing bottles, a doll family, a doll house with furniture, toy soldiers and army equipments, toy animals, playhouse materials such as table, chairs, coat, doll bed, stove, tin dishes, pan, spoon, doll clothes, clothespins and the clothes baskets, a DD doll, a large rag doll, puppets, puppet screen. Next. Crayons, clay finger paints, sand, toy gun, wooden mallet, paper doll, little car and airplanes, a table, an easel, and animal top tables. So there are so much of material you have to keep in the playroom. Next. Toy telephone cells. See the arrangement. So this is kept in the particular way and the child is able to take out. It is not very high and the child is not able to. Even many times I have seen that people have made the play therapy room, but those rooms are so protected, nobody else can enter. Even a child cannot touch anything. So this is for the observation. So child cannot play there. We have to observe that. So otherwise, अरे मटेरियल खराब हो जाएगा और कहाँ से लाएंगे, बजट ही नहीं है, इसको दोबारा भी यूज करना है और दोबारा नहीं यूज करने के चक्कर में कभी यूज ही नहीं होता और वो डस्ट लगी रहती है और एक दिन वो ऐसे ही बस कोई विजिट करने आता है, देखो दिस इज आवर प्ले थेरेपी रूम. आई एम गिविंग यू द ओरिजिनल एग्जांपल्स वेयर आई हैव वर्कड, वेयर आई एम वर्किंग. सो आई एम नॉट जोकिंग, दिस इज रियलिटी. They can't answer my single question if they will not use it. What is the point of keeping them? अगर खराब होने के डर से हमने सामान यूज ही नहीं किया तो उसका फायदा भी क्या हुआ? खराब तो होगा, यूज करना पड़ेगा और भी लाना पड़ेगा. इतना घबराते क्यों? जो पर्पस है उस पर ध्यान दो. तो नहीं समझ में आती बात, सिंपल सी बात है. आपको समझ में आ गई क्योंकि आप हंसे, आपको पता है ना. लेकिन आपके पास सेटिंग होगी फिर आपको भी लगेगा बजट नहीं है. अब क्या कर रहे हैं? बार बार तो अरे अलाउ ही नहीं करते, अभी तो लिए थे टॉय, कहाँ गए वो, है ना, और कहाँ से लाने हैं. तो थोड़ा सा टेक्निकल इशू है, बीच बीच में आ जाएंगे, बीच में मैं बताता रहूँगा आपको. स्मॉल ब्रूम, मोप, रैग्स, ड्राइंग पेपर, फिंगर पेंटिंग पेपर, ओल्ड न्यूज पेपर, इन एक्सपेंसिव कटर पेपर, हाउसेज एम्प्टी, बेरी बास्केट एंड स्मैशेस. सो नेक्स्ट स्लाइड. Precautions. What precautions we have to take while in the play therapy room? All playthings should be simple in construction. कोई difficult और complex material नहीं लेना. And easy to handle so that the child is not frustrated by equipment which he cannot manipulate. Simple, है ना. गाँव में छोटे होते पटोला, छोटी छोटी गुड़ियाँ बना लेते थे वो वेस्ट मटेरियल से ही, है ना, उसी से एंजॉय कर लेते. क्यों? इजीली बना सकते. आजकल बड़े कॉम्प्लेक्स टॉयज हैं तो वो वाले नहीं चलेंगे. सिंपल, इंटरेस्टिंग, ड्यूरेबली कंस्ट्रक्टेड. देखो उसका इलाज है भाई, सामान ऐसा लो जो आगे भी चले, है ना. टू विथस्टैंड स्टेनियस हैंडलिंग, लाइट वेट वुड मटेरियल. अब कांच के या चीनी मिट्टी के या उस तरह की चीज़ें ना लें, पॉट्स वगैरह ये इस तरह की चीज़ें, या लोहे की चीज़ें. आप कैसे लें? वुडन मटेरियल, हल्का फाइबर वाला आजकल जो आता है वो. द मटेरियल शुड बी केप्ट ऑन सेल्स विच आर इजीली एक्सेसिबल टू द चिल्ड्रन. एंड द डॉल फैमिली एंड पपेट्स अनब्रेकेबल. देयर शुड बी मदर, फादर, बेबी, सिस्टर, ब्रदर, ग्रैंड पेरेंट्स, डॉल फिगर्स टू इक्विप द चाइल्ड विद ऑल पॉसिबल फैमिली सिंबल्स. अब हमें क्या लगता है, तो 3-4 डोल ले लो, ये छोटी बड़ी ले लो, ये छोटी बड़ी ले लो, इंटरेस्टिंग. हमें ये कॉन्सेप्ट ही नहीं पता कि हमें फैमिली की डायनामिक्स को भी समझना है. तो वो कैसे समझेंगे? तो हमें फैमिली मेंबर्स लेने हैं डॉल्स में, सारे जितने पॉसिबल हो सकते हैं, और हो सकता है तो कल्चरली अडेप्टेड, कल्चरली रेलेवेंट हो। नेक्स्ट, a large sandbox to hold all the items. The sand is an excellent medium for the children aggressive play. It can be used as a snow, water, burying ground or bombs by children. So you can never know aggression को express करने के क्या तरीके हैं. बॉम्ब फेंकना है, मिसाइल फेंकना है ना? तो कुछ ना कुछ तो चाहिए ना ऐसा, जो सैंड आपके पास होना चाहिए, सैंड बॉक्स. Best results are obtained when all the play material in view and the child can choose his own medium of expression. You are not directing what material they should be using. You are just keeping it in the playroom. They will choose whatever they want to choose in non-directive play therapy. So child should be feel free to use the material in any way that he desires within the few limitations that are set up, without being restricted by a fear of soiling his clothes. अब कई बार कहते हैं कपड़े गंदे हो जाएंगे, है ना? होने दो. ज़्यादा इंपॉर्टेंट क्या है, चाइल्ड मेंटल हेल्थ या उसके कपड़े? हमें डिसाइड करना होगा. It is responsibility of the therapist to keep a constant check on the materials, removing the broken toys and keeping the room in order. हमारा काम सिर्फ इतना है, हमें ध्यान रखना है कि कौन से मटेरियल आउटडेटेड और नया लाने वाला है उसको लाके प्लेस करते हैं. नेक्स्ट, द प्ले थेरेपी पार्टिसिपेंट्स. द प्ले थेरेपी प्रोवाइड साइकोलॉजिस्ट विद ए टेक्निक फॉर अंडरस्टैंडिंग एंड हेल्पिंग दोज माल एडजस्टेड चिल्ड्रन हु आर ऑफन टर्म्ड एज प्रॉब्लम चाइल्ड. And the behavioral problems include problem of adjustment, study problems, speech problems, somatic problem, also including very repressed, withdrawn, inhibited child, running the gamut up to and very aggressive, uninhibited child. And a child with disability also benefits by a therapeutic experience if the disability is a source of conflict and anxiety and emotional disturbance. It is not something which is only done with the children of normal development. It can also be used very beneficial with children with specific disabilities, right? Next, what is the therapist role? It requires alertness, sensitivity, and an ever-present appreciation of what the child is doing and saying. So you have to be encouraging and appreciating the child in whatever way they are doing, right? What you don't have to do, don'ts. Do not patronize the child, hurry him or in impatience. Quickly do things for him that implies a lack of confidence in his ability to take care of himself. So you don't have to be impatient. You have to be very, very calm, sensitive and alert. Should not laugh at the child. अब कई बार होता है, हो जाता है. Should not betray the child confidence to the parent, teacher or anyone else. ये बहुत बड़ी गलती करते हैं. जो परफॉर्मेंस दे रहा है, जैसे परफॉर्मेंस दे रहा है, मम्मी पापा को सारा एक्सप्लेन. अब घर में जाके मम्मी पापा अलग से एक्सप्लेन करते हैं. अब अगली बार से ना थेरेपिस्ट अच्छा लगता है ना पेरेंट्स अच्छे लगते हैं. अभी आपका काम खत्म, अभी वो ग्रैंडफादर संभालेंगे, है ना? तो अभी हमें ये बड़ा ध्यान रखना होगा. ये छोटी छोटी चीज़ें हैं, हम जाने अनजाने करेंगे, हमें बड़ा कॉन्शियस होना पड़ेगा इन चीज़ों को लेकर. नेक्स्ट, व्हाट यू हैव टू डू, अंडरस्टैंडिंग, परमिसिव एंड एक्सेप्टिंग एट ऑल टाइम्स, शो ए जेन्युइन इंटरेस्ट इन द चाइल्ड. कुछ भी कर रहे हो, आपको जेन्युइनली इंटरेस्ट लेना है. ये नहीं कि आपकी इधर कॉल चल रही है, कभी इधर कभी उधर. नो, you have to be very attentive, interested. The child has to be treated with respect, sincerity and honesty. Respect तो सभी deserve करते हैं, बच्चा भी करता है ना? Should be kind and patient with a sense of humor that relaxes the child, puts him at ease and encourages him to share his inner world with the therapist. अभी यही तो अपॉर्चुनिटी है. अगर आपने पहले ही रेजिस्टेंसेस, बिकॉज साइकोडायनामिक पर्सपेक्टिव क्या कहता है, मैंने बहुत स्लाइड हटाई हैं, मैं वो साइकोडायनामिक और उन सब में नहीं गया क्योंकि मुझे पता था कि लास्ट में जल्दी जल्दी करना होगा तो फिर ज़्यादा टाइम नहीं मिलेगा. बट आपको क्या करना है कि वो समझना है साइकोसेक्सुअल डेवलपमेंट अकॉर्डिंग टू फ्रॉइड 5 stages, what is important, how they develop certain fixations, how you have to reveal, how you have to release that fixations. So you should be given an opportunity to the child that the child is expressing. Should be mature person recognize the responsibility that is entrusted to him or her, and then maintain a professional attitude towards work and maintain confidentiality. And the therapist must like children and know them. अब उस समय पे आपको क्या होना है, थेरेपिस्ट को मेच्योर तो हो आप, लेकिन आपका जो एटीट्यूड एक्टिविटी होनी चाहिए वो एक बच्चे के जैसी होनी चाहिए. क्योंकि अब बच्चे जो आपस में जो शेयर करते हैं ना, या हम उम्र हम साथ होते हैं, हमारे अपने ही उम्र के दोस्त क्यों बनते हैं? क्योंकि हम वहाँ पे बड़ा कंफर्टेबल फील करते हैं. बच्चों में भी एक एज ग्रुप होता है, वो भी अपने एज ग्रुप के बच्चों के साथ ही कंफर्टेबल होते हैं. तो आपको वैसा एक्सप्रेसिव होना पड़ेगा, आपको वैसा एक्सप्रेस करना पड़ेगा. नेक्स्ट, an indirect participant who is parents. The parents or the parent substitute often is the aggravating factor in case of maladjusted child. And thus, it is important that the adult also receive therapy or counseling, however, it is not always necessary. जरूरत है तो पेरेंट्स को अलग से काउंसलिंग शुरू कीजिए. In case of a child with disability, it seems more helpful to have the active participation of the parents, particularly if the child is intellectually disabled and the parents have a difficulty in accepting the fact. कई बार क्या होता है कि whenever the children with intellectual disability and some difficulties used to come to our clinics and along with their parents, so we identify them, their parents are not readily accepting the IQ scores and the level, है ना, what is level of functioning. So in such cases, many times it is very, very important that you include the parents along with your assessment of your child. So you just ask the parents to sit aside, not to regulate the behavior, but to just to observe. And after the child is out and you have sent out the child, and then you can explain, now you see, the typically developing children, then they can do better. For example, on VSMS. So you have to interview the parents, under-reporting, over-reporting. So how to deal with it? So you have to make an observation. So how you are observing? So you observe, many times the parents are not accepting, but when they see their child is doing in front of them, how he is performing, they will be able to accept it. And later on, when you are psychoeducating about their functioning, that there is a high level of acceptance. There is a proper acceptance of that. So that is very, very important. You involve those parents along with that. Next. So what are 8 basic principles of play therapy given by develop a warm, friendly relationship with the child in which good rapport is established. We know this is the backbone of any kind of therapies. A good rapport formation is very must. Even for the directive play therapy, first you have to go through some of the sessions in non-directive way. That is also advised. Accept the child exactly as he is. Establish a feeling of permissiveness in the relationship, though that the child feels free to express his feeling completely, and be alert to recognize the feelings that child is expressing and reflect those feelings back to him in such a manner that he gains insight into his behavior. So you have an important role to reflect upon. So that cannot be taught in such kind of lectures. That is a skill, and skill is learned, and learned through exposure. When you have a supervisor with you and you are dealing with certain conditions, then your supervisor help you in developing those skills. Next slide. Next slide. Back. Maintain deep respect for child ability to solve his own problem if given an opportunity to do so. And do not attempt to direct the child action or conversation in any manner. The child leads the way, the therapist follows. Here in non-directive therapy, child is the leader. You cannot lead and direct. You have to just follow. Do not attempt to hurry the therapy along. It is gradual process, and establish only those limitations that are necessary to anchor the therapy to the world of reality, to make the child aware of his responsibilities in the relationship. These are given by, numbering is wrong. Earlier 4, it has to be started with 5, so it is 8 only. So Virginia Oxlin. Next. Next slide. Thank you. So प्यार से सभी मान जाते हैं ना. मैं कहता हूँ नेक्स्ट नहीं करूँगा, नेक्स्ट नहीं करूँगा, नेक्स्ट हाँ जी सर आ गया. So directive play therapy. Now coming to the directive play therapy, how it is different from that. So purposeful activities such as games or make believe are structured by the counselor to elicit imaginative response from the client. And the counselor assumes the responsibility for guidance and interpretation of the play interactions. And the anxiety provoking situations are introduced into the play setting by the counselor. So here the role is different. This is directive, है ना, जैसे हथौड़ा मारने वाली है ना. मुझे लग गया था अंदाजा, मैं जान के अवॉइड कर रहा था मैडम को, वो ऐसे खड़े देख रहे थे. मैं कोई नहीं मैं कर दूंगा प्लीज. थैंक यू यार, मुझे एंजाइटी होती है, आप खड़े होते हो ना इधर. चलो. So David Levy developed release therapy, where the therapist provides security, support, and material needed to recreate a traumatic event, so that the child may assimilate the negative thoughts and feeling associated with the trauma. So here you see, जैसे CBT भी करते हैं ना, पॉजिटिव CBT भी आ गई है ना. इसमें हमें कोई नेगेटिव थॉट्स नहीं लिखने, हमें खाली पॉजिटिव थॉट्स लिखने हैं, क्योंकि नेगेटिव थॉट्स होमवर्क करके नहीं आते ना क्लाइंट. तो आप बोलो कि जो पॉजिटिव हुआ सारा दिन में वही लिखना है बस. देखो, दिस गिव ए ड्रामेटिक चेंज. और पॉजिटिव साइकोलॉजी का जमाना है आजकल. तो जो नहीं है उसके बारे में क्यों सोचना, जो है उसको एंजॉय करो, है ना. तो इसीलिए, बट इसमें क्या है कि यू हैव बीन गिवन दैट, कि यू हैव टू create that situation, structure that situation, that you can elicit that what exactly is happening and how you can manage that. So next slide. Gave Humbing disapproved the idea of flooding or pushing the child to release strong negative feelings, and he developed a structured play therapy which was implemented only after a relationship has already been established through the non-directive play therapy. मैं थोड़ा फास्ट करूंगा इसको, क्योंकि ऑलरेडी आपने नॉन डायरेक्टिव का ग्लिम्प्स ले लिया है, तो थोड़ा सा डिफरेंस वही है. सो नेक्स्ट स्लाइड. इट इज ए स्ट्रक्चर्ड थेरेपिस्ट लेड अप्रोच दैट यूज गाइडेड प्ले एक्टिविटीज टू हेल्प चिल्ड्रन एक्सप्रेस इमोशन, डेवलप कॉपिंग स्किल्स एंड एड्रेस स्पेसिफिक साइकोलॉजिकल और बिहेवियरल challenges. Next. So what is the purpose of doing that? Teach new skills. So some students or some children are not having that coping strategies and develop that skills to deal with that kind of situations. So you are developing new skills. Modify dysfunctional behaviors. You are just correcting their dysfunctional behavior through the role play activities and all that, right? So they address trauma or emotional difficulties, expression, and their reinterpretation of that particular event in a different way, right? Fostering therapeutic relationship and especially effective for children with 3 to 12 years. Dealing with anxiety, trauma, learning disorder, or behavioral issues, right? Next. So I'm not covering that theoretical background. You will read it somewhere, because this slide is also developed by AI. So you can even dive in and you can find. Next. So these are the different play activities in directive play therapies which you can use. The previous lecture was on AI, na? That is why I related with that. So I should admit it that this is through the AI. Otherwise, you will say that this is available on AI, sir. What is new? So toy telephone play, it facilitate indirect communication and emotional expression. Magic wand wishes reveal inner desires and emotional needs. Dalhousie role play, explore family dynamics and daily routine. Metaphor play, self-control games, art therapy, scent tray therapy, strategy game, destruction play. These all are different play type activities which is used for specific purpose. Next slide. Next. So what are the benefits? It promotes emotional regulation and expression, builds self-esteem and social skill, reduce anxiety, depression, behavioral issues, provide immediate feedback and skill building, and strengthen parent-child relationship when family is involved. Next. Next. So again, these are different play and activities. Next. These are the different clinical conditions where you can use different kind of play therapy activities. All AI driven. Next. So now you have to take a glimpse of that, what is different in both approaches. Just a quick comparison. Therapist, in directive, therapist assumes the position to know the best, and in non-directive, the client has the right to select his own life goals. Here, therapist, their client. So the session follow a more structural format. There is no strict adherence in non-directive. Therapist tries to direct the thinking of the client. Here, the therapist facilitates the client to analyze and synthesize and diagnose his own difficulty, predicts in future development and his problem. And here, the focus is on solving specific problem. There, the focus is providing environment that facilitates that client's inherent potentials for self-exploration, self-understanding and personal growth. And here, directive therapy is called the prescriptive, prescription-based. And here, it is permissive counseling. So you are allowing everything. You are permitting. Next. Just a repetition and glimpse of that all. What different therapies and how much is the response rate. Next. Confidentiality, you know, the common principle behind every therapeutic process. Informed consent and assent is must. Therapist competence, very, very important, because cannot indulge of any activity where you are not competent. So you should be taking supervisory support. Next. Dual relationship and boundary. Cultural sensitivity and inclusivity. Documentation and record keeping. And handling aggression and trauma play. Next. Next. Summary. So, evidence-based therapy lead to modality of cognitive behavior therapy and dialectical behavior therapy, which are more structured and directive. And still the principle of client autonomy and collaboration are emphasized, where directive to non-directive highlights a broader movement from seeing the therapist as an expert, imposing change to a collaborator, facilitating client self-driven growth. So one case I used to tell to all my students as well. There was one 3.5-year-old girl. She was presented with history of sexual abuse, and nobody was able to confirm it, who has done it and what happened to her. But the mother notices some private parts, some itching there and something like that. She consulted a gynecologist and she found that she has been molested by somebody and she has started in the school play school. She has started going there, nursery class. So in a private school. So mother was very concerned about it and very, very confirmed. है ना, you say mother को तो थोड़ा ज़्यादा ही पता चल जाता है ना, उस हिसाब से अंडरस्टैंडिंग होती है. तो उन्होंने FIR करा दी. अब FIR करा दी तो थोड़ा डाउट हुआ स्कूल में कोई है. अब स्कूल में कौन निकला वो बाद में बताऊंगा, पहले वो लेके आए उसको, भाई आप ना एक बार साइकोलॉजिस्ट से इवेल्युएशन करा लो कि क्या पता कुछ और है, क्या नहीं है, क्या है. सो उस बच्चे को लाए तो आई स्पेंड सम टाइम विद हर, दैट है ना, आई गिवन हर सम पेपर्स, क्रेयॉन, कलर्स, एवरीथिंग देयर. सो आई आस्क्ड हर टू ड्रॉ एनीथिंग यू वांट. शी ड्रॉ ए स्पेक्स and some beard and some face like structure, but you cannot easily make out. But when you ask her what it is, chashma, है ना, ये दाढ़ी, फेस, है ना. सो वैसी अपीयरेंस का एक एम्प्लॉय नहीं था, मैनेजमेंट ट्रस्टी था उस स्कूल का, उनकी वाइफ प्रिंसिपल थी, उसका हस्बैंड यूज्ड टू डू दैट and he was arrested. So many times these students, these small children can't explain, can't help you in understanding, and these different kind of play activities, small kind of drawings, arts will help you understanding and analyzing their internal feelings. And she was very feared of going into the school. That time they realized that what is happening in the school, she is not going to the school, even a 3.5-year-old child, right? So I clearly remember that case, and I just made a report that she is terribly fearful of certain kind of, this kind of person, and who is having these features. I cannot comment who is it, है ना. Although mother used to tell me that school में कुछ है. अभी ज़्यादातर क्या जाता है, चपड़ासी हो गया, टॉयलेट के बाहर स्वीपर हो गया, इन पे जाता है हमारा, है ना. बट उसमें प्रिंसिपल का हस्बैंड था मैनेजमेंट में. So you have to be very, very, है ना, accepting, caring, understanding, sensitive, alert. As a therapist, you should be reflecting, you are analyzing a child, है ना. So you must be competent in that, you must be understanding in that, you must be having a thoroughly understanding of that, and you have to maintain a confidentiality. Yes, you may be given that role, you can given such kind of cases to evaluate. Then what you, that dilemma was there, but we could come out with some inferences out of that. So on the basis of that, that is a circumstantial, है ना. अब psychological reports are the not the evidence. जैसे ना forensic investigation में कुत्ते का सहारा लेते हैं ना, dog, लेकिन कुत्ते को witness box में तो नहीं खड़ा करते ना, कि जा तू गवाही दे, तू नहीं पकड़ा सुराग, है ना. अब वो एक फर्म हमें इंडिकेशन मिल गया, उसके चारों तरफ हमने उसको इंक्वायर करा, तो जब इंक्वायर हुआ तो फिर वो कंफर्मेशन. समझ गए मेरा पॉइंट. तो आप एज ए साइकोलॉजिस्ट बहुत सेंसिटिव सिचुएशन में होते हो, आपको बड़ा ध्यान से करना होता है. तो विद दीज वर्ड्स आई विल समराइज एंड कंक्लूड हियर. थैंक यू.
Does anyone have any questions regarding this session?
Yes, please. Microphone. Our question is, from the psychodynamic and psychoanalytic point of view, fixation at oral stage lead, how you can resolve that through the play activities, है ना. So this is 0 to 18 months old age, and the main object is, you see the nipple and the oral, this gratification, and they, because you know the concept of refrigerator mother. So the women, those who don't breastfeed their children and they are not managing their need, many times it's not only the hunger they are striving for. The children are looking for some warmth. So this warmth is missing, right? So you have to create certain kind of, for example, in that case, dips also, he is a very infantile kind of sucking that bottles, right? So through that non-directive play activities where he was using that object in a different way, and the therapist was observing and reflecting back on certain things. So as soon as the child gets mature, so they are very apparent to them. For example, thumb sucking. This is another example. They are fixated into that particular stage because the mother has not given ample time or ample warmth and care and attachment to that child during that phase, 0 to 18 months, right? Because of any reasons. But that stage has happened. So resolving that stage itself is a very big task in later age, right? So these people used to have smoking habits and some kind of compulsive addictions, so which very hard to deal with that. But later stage they can be explored through the visiting their early lives, like the Freud used to do is in convergent hysteria cases, right? So going back, what happened during that. And once that they reach to that particular stage, and there they can identify what is the replacing. But in psychoanalysis, we generally give interpretation, why this is happening, right? And this interpretation is not a correction of that, but resolving that particular emotion itself is a relief, right? They may not be leaving the substance, but they are now realized their weakness, their parts, their problem. So in play therapy, certain play activities, maybe I've not encountered such thing, but certain activities during the bottle sucking act was there. So as soon as the child realizes his own potential, his own internal feelings and all that, because he was abandoned by the mother. Now the mother is more caring, supporting, helping, looking after. So that particularly helps in, and the mother also realizes that. So that overcoming that particular thing through different ways can reduce that particular behavior. Now his wish fulfillment is done through different means. So bottle has been broken. So there is no further need for bottle. Now the mother itself, the object itself is available for the attachment and warmth. So if you correct that feeling, connect that thing, then there is no object required, right? So maybe it's very difficult to answer in that way, but it's all working with the child. What happens and what will help that child in particular, we can't explain in beforehand, right? Whatever happening in that way, right? So this is all working basically. Thank you. Any other question? मुझे पता है जाना है सबने. पीपीटी दे देंगे आपको. मैडम खुश हो जाती हैं जब कोई क्वेश्चन नहीं है. ठीक है, टाइम बच गया. चलो ठीक है ना, आइए.
Thank you, sir, for this very engaging and interactive session.
As we come to close of this enriching CRE workshop, it is both an honor and a privilege to deliver the vote of thanks on behalf of MJRP University. We are deeply grateful to all the distinguished speakers who graced this platform with their insights, expertise, and dedication.
A heartfelt thank you to all participants who joined us from different places. Your enthusiastic presence and active engagement made this workshop interactive, thoughtful, and truly collaborative. With warm regards and immense gratitude, thank you all. Can the media department please turn on the cordless mic, please? Can the media department turn on the cordless mic, please?
कनेक्टेड नहीं आएगा इसलिए क्या कह रहे हैं एक बार बोलते क्या पहले सीआरएम मेंबर्स को जो कलेक्टर सर्टिफिकेट्स मैम
And take the certificates. Akanksha Chopra, Aman Mishra, Ambika Sharma, Ambikesh, Amit Meena. Quickly come on stage. Akanksha Chopra, Aman Mishra, Ambika Sharma, Ambikesh, Amit Meena, Anamika Sharma, Anita Saini, Anjali Meena, Ankit Chaudhary, Anuja Chaturvedi, Arpit Kumar Yogi, okay, Avinash Vittal Aneria, Chavi Parikh, please come. Anuja. Your name? Chavi, please sign. Anuja. Signatures. क्या नाम है बेटा? अनु छवि एक से छवि का नहीं है ये रोनी देशना तुम इधर साइन करो देशना मोनिका शर्मा नॉन से बना दिए मैडम मीनाक्षी ने पूछो बने हुए हैं इनके ईशान अरुण आपको बुलाया जब बुला रहे हैं आपका नाम तभी आएगा गुरसिमरन मोनिका चलो ये लो मोनिका देशना
Non-CRR candidate which are from the outside Jaipur, they can collect your certificate from outside, from Sunita ma'am, please. Sunita Saini ma'am is outside. So non-CR candidate who belongs to outside Jaipur, they may collect your certificate from outside, please. ये लो गुरसम हाँ एक हर्षिता गुप्ता हिना खान जनकराज मीना कमालिका विजेता थोड़ा जल्दी आ जाइए प्लीज जनकराज ये कांग्रेचुलेशन थैंक यू थैंक्स
जनकराज
लो बेटा
आप साइन कर दीजिए
कविता नाहर केजिया इज देयर खुशबू खुशबू मौसम जाट लगीमा जैन मेघा देवेंडा मेघना जाट महक रंजन हाँ दे दो चाहे यही बैठ जाओ देते जाएंगे साइन कर ले बेटा मिहिका मित्तल हाँ
साइन कर
साइन करके जाना बेटा है ना हाँ हाँ मिहिका मित्तल मिहिका मित्तल इज देयर निधि गोयल महक रंजन
निधि गुप्ता
आई निधि गुप्ता गोयल नहीं है बेटा गुप्ता है
दो है
निमिषा शेखावत निशिता निधि गुप्ता आगे निमिषा निष्ठा क्या नाम है
निष्ठा ये निष्ठा
नुपुर पलक कौर पंकज राठौर, पंकज राठौर, पूजा रेगर,